Hello again from Thessaloniki. This is the second day of the 4th International Meeting on Minimal Invasive Extracorporeal Technologies, organized by MiECT, and trying to bring forward all the advancements in MEAC technology. So all the key opinion leaders in the panel are here, and there are also a lot of online participants already connected, and we'll immediately start with the first session, MEAC in clinical practice, moderating by Professor Gunaidin and Dr. Elazawi.
Hello again. We are waiting a very intensive teaching and discussion full of half days. So we start with Robert Baker from Australia, Adelaide, and he's a professor of perfusion sciences, and he's going to talk about the implementation of MEAC in clinical practice. Hi, Rob. How are you?
Good, thanks. I wish I could be with you all there. Seems very unfair.
Okay, so we are listening to your presentation.
Okay, thanks very much. Yeah, look, I've been asked to talk about the implementation of MEAC in clinical practice. So I've sort of framed something that I think we can talk about. I have no conflicts relevant to this presentation. Back in 2009, a colleague of mine and I wrote this paper, Implementing Change in Perfusion Practice. And as I was sort of thinking about preparing to talk to you guys today, it occurred to me that some of the themes that we talked about in our own practice and in this paper were very relevant. In particular, we adapted this model for clinical effectiveness to use in instituting changes in clinical practice. And I'm going to sort of use that as a tool or a lever to go through this presentation with you. But if we start over here, and when I first got involved with this group, it was very much, where did MiECT sit in terms of known best practices, and how were we able to contribute to research to learn and to develop whether it was a best practice or not? And I think this group has really contributed to helping answer that question. And we've seen now in both the 2019 European guidelines, which have 3 recommendations in relation to MEAC, and the blood management guidelines of the STS, SCA, AMSEC, and SABM, published in 2021, in which there was a recommendation in terms of utilisation of MEAC for reduction of blood loss and red cell transfusion. And most recently in the cardiac surgery associated kidney injury guidelines that have just been published, there's a recommendation there that MEAC be considered. So I think we've really moved a long way in that continuum of knowledge, in that I think it's quite reasonable to start to say that we know that it's a reasonable practice and it's developed into a best practice, and we can consider it as such. So in Europe, I think we're all sort of familiar with this sort of adoption curve. In Europe, you're on the upslope, probably past the early adopters and heading towards the early majority. But in many other parts of the world, as you know, we're very much in that lead-in phase where it's really the enthusiasts who are still still taking the technology into their country. So there's a long way to go in terms of getting MEAC into common practice. But if we move on, we know what we should be doing, and we need to know what those proper techniques are and procedures, and we need to know them, but in an environment that can support them and can develop them. It's no good bringing things into systems if we can't bring the support around that. The topic of adoption of technology in cardiac surgery and surgery in general has been well published. The first paper there on your right is a paper published in 2006, while the one on the other side is 2022. And this story about implementation science is really interwoven with the adoption of technology now in cardiac surgery and other disciplines. But they all have common themes. And in relation to implementation, there's the identification of the problem, there's gaining a consensus about how important it is and why we should be looking at using it. Then there's obviously going to be a variety of different ways we can do that, a variety of different options. But then it comes down to the important part in terms of site implementation and bringing it to your own home, our own hospitals. And we're going to just talk about that a little bit. Firstly, talking about planning. Clearly, industry partners are essential in implementing a MiECT program. I was fortunate enough to see a number of different MiECT systems in a number of different hospitals in Europe. And the overwhelming support that one needs to get from the industrial partners in terms of, just the technical aspects, the logistics of getting the right equipment in the right place at the right time, and helping us design what is an appropriate fit for one's institution is very important. Similarly, the development and the planning of the team. This group has highlighted throughout that it's a multidisciplinary team approach. You can't take this into an institution unless you have everyone on board. And that's through every phase of the implementation process. And I think one of the most important steps is both to manage the expectations of the team and also to manage the timeline of implementation. Now, as I said, I've been fortunate enough to have an opportunity to visit many of the sites in Europe that are using MiECT. And it's this partnership that's really important in training. Industry and the early adopting clinicians are important in leading other local multidisciplinary teams in getting to a position where they can actually implement MiECT in their own hospitals. There's a number of different pathways that we can use for this. There's visits, as I mentioned, there's the master classes, there's proctoring and mentoring. I believe that the proctoring process around this is incredibly important when you're bringing new technologies and often new hardwares into an institution. And of course, there's a lot of hard work associated with implementing something like MiECT. But being able to do the right procedures, the right work at the right time with the right system support is fundamentally what we aim for as clinicians all the time. So if we look at this implementation process, I think probably the most important step of it is that continual evaluation. Are we doing the right thing? Are we doing MiECT properly? Are we measuring what we're doing? And if we're not, how do we improve on a day-to-day basis? So clearly what we're talking about there is you need a solid quality assurance program, and you also need to be improving if you need to be. So to finish up, sharing how to do it right with others is most important. And this group of people associated with the MiECT group has led the way in terms of opening the door for other units to participate in adopting MiECT. Thank you very much.
Thank you very much. And so how do you see now the current implementation ratio or percentage of MEAC in the world or in Europe versus US or Australia?
Well, in Australia, we've had a very low adoption rate. We've actually got 2 sites now that probably by the end of this year, early next year, will be up and running. One in the West and one in Adelaide, where I'm from. But I think it's a cliche now in many ways, but COVID has really slowed down the growth of MiECT, I believe. There's been such a big focus in other areas of perfusion. And it's only now that I think people are seeing a bit of clean air to really embrace again this technology. But I think the literature has, and the inclusion of MiECT in so many guidelines now is a solid step going forward.
Okay, thank you. Any questions from?
Yeah.
Yeah.
Hey, Rob, it's Mike.
Yes, mate.
Hey, thanks for the presentation. And maybe you can comment as well. And something that I've noticed just over the last 15 years has been that when you and I started having the conversation around, being able to adopt this into the clinic, it does seem that, from my perspective, that the surgeons are a lot more open to, to the perfusionists approaching, the surgical team to adopt this. And I kind of use our experience in Adelaide. It seems like, because of the work that you had done to prepare yourself and go back to the team and be able to say, hey, I think we can implement this, and these are the clinical advantages. I think when we were doing that kind of implementation back in 2005, 2006, it was a lot more of a challenge. But maybe you can share your thoughts on if you perceive there to be maybe more acceptance within the surgical community that's using a different perfusion approach to deal with patients that are more complex.
Look, I think cardiac surgery, like all aspects of cardiac surgery, cardiac surgeons, like all parts of cardiac surgery, have developed enormously over the last decade, 15, 20 years. And there's a clear recognition that in all aspects of what we do, there needs to be a recognition of the whole team. We've just had our first multidisciplinary national meeting of the surgeons, the anaesthetists, and the perfusionists, and that was a great success. And it signifies where, as a community, we are going. If we can work together and we can conference together and learn together, it just gives us a much greater opportunity. And I think that the three professions are listening to each other a bit more and are becoming less isolated and more communicative. So I think it's an overall development, and I think it's a really healthy one.
Thank you. Any other questions? Okay, Rob, thank you very much. So we're going to the next speaker.
Yeah, our next speaker, we're making a big jump from Australia to Canada. Next speaker is Cyril Serik. He's currently the president of the society, and he's a perfusionist. And the topic of his presentation is venting options during MEAC, which definitely is one of the things that perfusionists are always talking about when it comes to MEAC and implementing it beyond CABG surgery.
Thank you very much. Slides. Whoop. Oh, wait. Yes, so my topic today is more technical on venting during MEAC, and hopefully after this presentation we can just go around the table and do a small discussion about what the various places do for their venting techniques. So, I mean, we all know why venting is important. We need a bloodless field. We want to unload the ventricle and de-air the heart. Obviously, for CABG, I think the bloodless field is probably the most important. But the big drawback for closed circuit is blood volume is being removed during the venting. So we know these patients are very volume sensitive. So taking blood away from your circuit because it's closed can cause issues with flow, especially if that volume is not promptly returned. Air during the venting is often mixed with blood, so we definitely need to remove that air before returning the blood, and if we don't take the appropriate precautions, then that can lead to air getting into the closed circuit. So that remains a technical difficulty as well. So all of this certainly increases the complexity of the circuit. So it's something that we all must think about before going further. So basically, these are the options. You know, we have the aortic root vent, the pulmonary artery vent, and LV vent. And I'll just go through those in some more detail. If you look at, I just took this from the comics trial. If you look at the distribution of venting, I don't know, do I have a pointer here? Maybe not. Okay, it's just, so if you look at, it, there's a little lag, sorry. So LV venting, about 20% of our of the cases, and out of 1,000, basically 20%, the right superior pulmonary vein and left ventricle. We have LV or pulmonary artery venting a little bit more in a MEAC group, 13% versus conventional group, but there is pulmonary artery venting in the conventional group. And, this was, 85% of these patients were CABG. So you would expect aortic root venting to be prevalent. And we see that in at least 56%, 57% of the cases. Doesn't matter if it's conventional or MEAC. So if you look at pulmonary artery venting, one of the advantages is you can connect it directly to the venous line, because there's very little air-blood contact. The performance depends on the negative pressure generated by the centrifugal pump when you do that. So that becomes a limitation. So if you want to increase the vent, you basically have to try to increase your flow. One of the disadvantages, though, it doesn't drain the LV directly, and you cannot actively de-air the left ventricle with a PA vent. And we can talk a bit about that, bit more about that at the discussion. Aortic root vent. Well, there's two types of venting when you're venting the aortic root. There's two techniques, basically: the side biting clamp and single clamp technique. When you're venting the aortic root, just using the side biting clamp technique, you have the advantage that you can directly connect the vent to the venous line. There's no blood air contact. The unfortunate thing is it depends on the negative pressure generated by the centrifugal pump when you directly go into the venous line. And but one of the disadvantages is you have increased risk of neurological injury, and that's why some centers prefer to use a single clamp technique, because you have you're manipulating the because with that side biting clamp, you're manipulating the aorta a bit more, so there is the risk of atherosclerotic emboli. And with the single clamp technique, it's you can decrease the risk of neurological injury. It does require a different mechanism to de-air the blood before reinfusion, especially during the proximal anastomosis. Distals you could there shouldn't be much air-blood contact, but once that aorta is open and you're actively sucking on the vent, you're going to get a lot of air back. So you have to deal with that some way. And again, the big disadvantage is increased blood-air contact. And direct LV venting. Again, the advantages: you have better LV drainage, is effective de-airing during the reperfusion phase, so you can, this is very good for or needed during valvular surgery. And again, you can't drain directly into the MEAC circuit without risking air entry into the circuit. So again, you need to have some sort of mechanism to de-air that blood before reinfusion. I mean, you just can't avoid the blood-air contact. So some of the techniques that used during MEAC to overcome these things. One is a bubble trap, as we see here on the right. Use this bubble trap here. Sorry, gonna go back. So with this bubble trap basically is directly connected into the negative side of the pump. So either you can do it before your air purge air purge system. Here it's between the air purge system and the pump. And if you look at and this is just this is Thessaloniki's group, where they have a PA vent and an aortic root vent basically inline. You just turn a stopcock up here on top. You turn a stopcock. You would to open up the vent, and you'll actively to start actively venting. Any air would get trapped in that bubble trap, and you can take that out either through using a syringe or hooking up directly to a cell saver with negative pressure through the cell saver. And this is just a picture description, just showing, so you can hook up the aortic and PA vent directly, de-air through that bubble trap. When you need to take air, you actually have to take the air out. You either have to stop the venting, or you have to momentarily stop the venting, or have enough negative pressure on there to overcome the negative pressure of the pump. Another way to do this is through a direct hard shell cardiotomy, and intermittently clamp that into the venous reservoir. And with this, you can independently put a pump on the aortic root or LV vent, and instead of having it drain passively through the negative pressure generated by the pump. So the unfortunate thing about a cardiotomy, having that cardiotomy reservoir, is, again, you still have air blood interface, although it's not as significant as conventional cardiopulmonary bypass. And you do have the risk that if you let that clamp go, then you can certainly entrain air into the whole circuit and cause yourself more problems. So, but this is certainly a technique that you can do. We talked about yesterday about working with our industrial partners, and we worked with Spectrum Medical with their for the quantum heart-lung machine, and ran some of the first cases on mini bypass using quantum. And one thing that we came up with was what we call the volume add pump, where we're able to any vented air will be sent into a cardiotomy reservoir. You have a pump placed between the reservoir and the venous line, and we're using level sensors. Here you can see on the top here we have a yellow and a red level sensor. The yellow level sensor, when tripped, will actually turn that pump on, and you can that'll directly automatically infuse blood back into the venous line to try to keep up with that volume displacement that is so critical during these cases. And if the level hits the red sensor, then it will automatically turn that pump off, so you have no risk of entraining air into the venous line. You can also open, we have a bypass there you can see with the clamp on it that you can open automatically, or not automatically, but manually, sorry. And, just in case you need to add blood a little faster, if you will. So you can infuse it, you can use this for a closed reservoir as well. I know HEPA is using much the same technique, but they're using negative pressure in the venous line. So as soon as the negative pressure gets below a certain level, and you can set it -70, -80, then that pump would automatically start and automatically give blood into the venous line. And this is this is just a small little video showing you how this is actually working. And here you can see, it's automatically giving. It's set at 200 mils a minute, as you can see there to the right, and you can adjust that up or down depending on how fast the vent air is or the vent blood is coming back. And the vent blood also has time to de-air in this reservoir as well. And so venting MEAC during MEAC can be safely done, provided but I do think you need to know the limitations of how you're using the vent and why you're using the vent. And we have to make adjustments accordingly. So even though, one of the big principles of MEAC is to avoid that air-blood interface, air-blood contact, I think, we have to vent the heart. So it's we cannot eliminate air-blood air-blood contact, but we can certainly try to reduce it as much as possible. Thank you.
Thank you, sir, for a very interesting presentation. So if I get you right, the last video you showed is your preferred way of doing it.
Yes, that's our preferred way of doing it. And like I said, something that we came up with working with Spectrum Medical to kind of make this a more automatic procedure for venting.
But this is your choice beyond CABG, or meaning when you employ MEAC involves surgery, or is it also the way you're doing it in CABG? Because
no, we'll do
CABG, it would be a bit.
Well, CABG, but you're still, we use a single clamp technique, and so you still have to, we still increase the vent, and you get a lot of air back when you're doing the proximal anastomosis. So yes, we would do the exact same for CABG as well.
So I have another question for the group here in Thessaloniki, because I know that they have, I think, 3 vents in the system. You vent through the aortic root, you vent through the pulmonary artery, and you vent through the pulmonary vein. So at which phase of the operation do you use which vent?
So normally we use 2 lines to which we connect the vents, which offer a very good condition for the perfusionist regarding the preload and afterload of the centrifugal pump, as well the decompression of the heart. So one line is the pulmonary artery vent. It's absolutely safe. There is no air interaction, and it's very easy to manipulate with the baby bubble trap which we use. All the vents are connected directly to the venous line. Take advantage the negative pressure that the centrifugal brings to the venous line. The second line is divided in 2 vents. One vent is aortic root vent. It is well known that it's a closed system, and as soon as we use this aortic root vent, for example, for a coronary artery disease, sometimes we suck air from the coronaries to the aorta. So in this case, in order to avoid air redirection, we use this vent intermittently, and we operate this vent when the surgeon claims that the field is not so good. When we are doing aortic valve or mitral valve, we use pulmonary vein vent in order to subtract some volume from the left ventricle. So it's easy for the surgeon to operate because the surgical field is clear, and every time that the left ventricle filled with blood, we operate the left ventricle vent. So we use this vent intermittently. There is air interaction, but we have a level at the tube, and when we see that comes air, we stop, and we continue when the heart again, the left ventricle filled with blood. So it's very easy to manipulate with the mini bubble trap. There are a lot level of safety. First level is the mini bubble trap, and the second level is the normal bubble trap, and there's intervention between these two traps from the venous occluder from the quantum. So it's absolutely safe, because if air comes to the small bubble trap, there is a sensor below this bubble trap which give an order to the centrifugal pump, go to 0, the occluder will stop, the perfusion will reactivate the centrifugal pump, the airing the small bubble trap, open the venous occluder, and deliver the vents air-free back to the circuit.
If I may, you can avoid this LV vent if you don't want to use it and use this cell saver. But we are using it for dual purposes, as Cyril pointed out, because we de-air with double vents at the end, left ventricle and aorta. And we retract first the LV vent and leave for the very latest minute before coming off the aortic root vent. So we use them, as I say, for dual purposes. Intermittently, if there is heart on the LV, that creates a trouble to stitch, but again for retracting the air at the end of the operation.
Yeah, I think the big challenge is if you're getting a lot, for us anyway. I think when you're doing valves and you're, if that vent is high, right, and you're getting, the surgeon's getting flooded in the field, you want the vent on high, then it does become, very onerous. Like you're not taking care of the patient. You're just, the perfusionist back there is just operating that vent, trying to get rid of the air to get that volume back to the patient. So I think that's the biggest, challenge, venting. How do you guys vent? How did you do it?
In simple CABG surgery, we went through the aortic root, and we de-air through the bubble trap and the automatic venous occluder. In valve surgery, we vent into a soft bag, and this soft bag is open to the air, so it does gross air removal. And from the soft bag, we go back into the venous line, and in the venous line, all manually. And in the venous line, you again have your bubble traps, and it works very good. And I tend to like a soft bag more than a reservoir, because a reservoir has too much, it looks too much like a conventional system when you have a reservoir. I find it very interesting that in combination with the quantum, you can automate the thing, and it makes perfect sense, but it's still a reservoir. I like the soft bag more, but this is just my.
I mean, I've done it both ways, and the reason why we switched to the reservoir is, you know, it's not that it sounds easy. Oh, we're going to use a bag, but again, you got a lot of air. Like, you're constantly taking that, trying to get that air out of the bag now, right? And you know, we would have that hooked up to the cell saver, and so you're constantly manipulating clamps back and forth, so it can be very busy. Adrian, how are you guys doing it in Germany?
Hello all, good morning. Yeah, we have to vent, otherwise we can't provide you optimal field to operate a patient. So we have to distinguish between the bloods. There's good and there's bad blood. So the blood directly coming out of the vessels or the heart, you can directly vent to the system. So that's good blood and should be not in an open reservoir, I guess. And there's also bad blood. That means blood which bleed before go through the vessels and through the walls of the vessels, and then it's already activated, and you can put it also in a reservoir. I would say yes, MEAC system should appear nice, should be appear as a MEAC system. But if you need an open reservoir, please, no problem. So it's not a model or thing or something else. So to have an open reservoir for big operations or for operations with a multi approach, so it's okay. I would support it. How we do it in Cosvic, we went directly from the pulmonary artery in the valve cases, and in the cabbage cases directly from the aortic root vent.
I also want to ask a question. So, finding this experienced perfusionist here. So, for the new beginners, the main problem is the drainage of the heart through venous line or whatever. So, what is your suggestion? Is the cannula important, cannulation important, or surgeon place the cannula is important, or perfusionist skills are important?
First of all, good cannulation. If we have a good cannulation, you will you are able to provide a good field for the cardiac surgeons. So that's very important. Also to replace the cannulation and to talk with each other between the surgeon and the perfusionist and the anesthetist, of course. Very important.
Do you use TE for cannulation, or anybody here? Transesophageal echocardiography?
I think it's a necessity. You should use it and do it with TE. We always do it like that, and I think it facilitates the position of the cannulas.
Mm-hmm. Thank you.
Yeah, I think we don't use it routinely for cannula placement, but to Adrian's point, I mean, you know, as soon as you go on bypass, whether if you don't have good flow at the beginning of bypass, it's always a cannulation issue, pretty much. So you just have to ask the surgeon, I don't have good venous return, you know, but it's like that with conventional as well. I just think we're more vocal about it with MEAC. It's like, I don't have good venous return, you're gonna have to adjust the cannula. So I think the surgeon and surgical technique is the most important for optimal flow during at the beginning of the case. Anyway, during the case is a little bit different story, but you know, cannulation you have to have the proper cannulation, otherwise it's not going to be a good case.
Well, in my opinion, it is the cannula which is very important. Cannula drainage dynamics means its design and positioning is important for along with vacuum assisted venous drainage or with KVAD.
Okay. Thank you. So no other questions. We go to the next speaker. So the title is Value-Based Cardiac Surgery by Vladimir Popov from Moscow.
Dear colleagues, thank you for the opportunity to take part in such an innovative and creational event. This is great privilege and honor for me. And special thanks for Professor Anastasiadis. So I have to discuss about value-based cardiac surgery. Cardiac surgery is now dealing with high-risk patients, is forced to complete with endovascular techniques and needs a significant reduction in invasiveness. The central position of this belongs to minimal invasive perfusion technologies. It would be rail-based cardiac surgery. We have discussed yesterday about that Dr. El Esawi and Dr. Bennett, and I would like to continue. At least 40% of patients undergoing cardiac surgery are high-risk patients with severe concomitant disease, with obesity, diabetes, respiratory dysfunction, renal dysfunction, multi-arterial disease, and other severe comorbidities such as, and the new frontier of perfusion, modular minimal invasive extracorporeal system for such type of patient. With the advantages of MEAC many times discussed yesterday, and its strong evidence, and there are other means approved physiologically, reduction of systemic inflammatory response, improvement of coagulation, management, accelerated recovery, good in transfusion, protection of neurological function, kidney function, myocardial protection, decreased mortality rate, quality of life, and economic efficiency. The problem is implementation and learning curve, especially in our country too. Here's a real history of my effort in implementation of this technology. We have implemented MEAC since 2011, but real progress began since 2019. Then we are starting to collaborate with Thessaloniki team and Professor Anastasiadis and MiECT. We took second type of MEAC system and adjust it, set up it for our particular situation, and we will continue to improve this secret and perfusion with the help of our experienced colleagues and companies. Next, we are going to introduce a type 4 circuit for further increase safety of perfusion. But really, in our practice, we now use two ways to solve the problem of negative consequences of perfusion. One of them, eliminate of consequences, and we are dispose low volume continuous hemofiltration. Our way, decrease of invasiveness of CPB. It's MEAC, of course. Hemofiltration technology has been implemented by our Center for Complex and Prolonged Cardiac Operation, and it gives no bad results in our experience. And now we have conducted research comparing line, clinical results, and immune response in two groups of high-risk patients undergoing cardiac surgery with conventional CPB plus hemofiltration or cardiac surgery with MEAC system. This study is a pilot project. We conducted propensity score matching, and 37 patients were included in each group, and their perioperative parameters were studied and compared. According to the main clinical characteristic, there was no statistical difference between the two groups. There is no statistical difference in the main indexes of comorbidity, renal dysfunction, diabetes, associated with pulmonary problems, and the level of the Euroscore 2. Intraoperative parameters such as intraoperative blood loss, time of CPB, aortic cross-clumping time, as well, were also was the same. Significant differences was observed in postoperative data such as free hemoglobin level, dopamine administration, noradrenaline administration, lactate level, PaO2, VO2, urine flow as well. Significant differences was observed in duration of ventilation time and duration of hospitalization. The statistical differences was obtained also in the level of procalcitonin in two group. CRP positive level, STREM, sorry. Interleukin 6 levels, strong evidence. Interleukin 10 also. Postoperative blood cell level also. In conclude, minimally invasive perfusion technology provide better end organ protection in high-risk patients in comparison with standard CPB circuit in combination with hemofiltration. A less pronounced manifestation of systemic inflammatory response in the MEAC system group may be relevant for patients with chronic organ dysfunction. So how to improve MEAC program in our center in Russia? Dissemination of technology and knowledge in Russia, involvement of specialists and professional societies, gaining the experience, support for industries, collaboration with MEACTs, and key technology world leaders. What we have to do, implementation research in our center, establishing MEAC training center Vishnevsky, organize webinars and including MEAC in our events, such MEACs, it's events regarding minimally invasive cardiac surgery, implementation type 3 and type 4 perfusion. Thank you for your attention.
Thank you very much. So this is an interesting topic we have been discussing from yesterday. So is the high-risk patients the real target of MEAC to show clinical differences, maybe clinical impact? So do you do any specific different approach to high-risk patients while using MEAC, or use the same circuit with the same strategy?
No, now we have some challenges regarding circuit in Russia, but we use with system especially for this type of patients, such type of patients. It's very good system, and we have good results for this, and we start to make research and look into this problem.
Thank you. So I also want to ask the panelists, the experienced perfusionists, Adrian, what do you think? Is the high-risk patients the real population that we should be interested in?
Yeah, I think even that patients are very interesting because in a regular case, we can win a little bit with a better system, with a better approach. But even in that borderline patients, we can win much more. So even that patients are very interesting for us and for the procedure, I guess. Yeah.
Okay. Yes, Rajay.
Yeah, in my opinion, after the pandemic, most of the patients we are dealing are associated with comorbidities. So they are in high risk group only. So why not to offer the advantage of the technology to all the patients, deserving patients?
Thank you. Ignacio is here. So, hi, Ignacio. So, what do you think the use of MEAC in high-risk patients? So
I have a problem with connection, Prof. I don't hear you.
Oh, okay. So, yeah, Philip, what do you think? The high-risk group.
I think the high-risk group should be the normal choice in that way that actually MEAC is already combining the best strategies we know for high-risk patients. So it forces you even more to use these techniques, whereas if you would use a conventional system, you might make some, well, let's say, reductions in quality because it's easier or whatever it might be, and that you can't do with MEAC. So I think it should be probably the right choice to use that in those patients.
Thank you. So, Dr. Beretta, do you use MEAC in your high-risk patients in your clinical practice?
Yes, absolutely. I think a high-risk patient should be the best candidate for these technologies, for the advantages that you can obtain in these patients. Absolutely.
Thank you.
May I comment?
Professor, now I listen.
Okay.
Just a comment to what you are discussing. I definitely agree that the high-risk patients should be our target, but you shouldn't underestimate that if you want to use that in this case mix, you should, before that, use it to the average patient. Because it's very difficult when you try to implement a technology to a complex technology to a difficult case, when you are not get used to do it at the easy cases. It's like the off pump. Some people, they say that they will reserve it for very tough cases, but then it's very late. So what is the case and what we are suggesting is you should have it to all cardiac case mix. So as all the team knows exactly what to do, and when the difficult cases come on board, then it will become easy case by definition. So don't leave it selectively to the very tough cases. It's wrong decision. And that's why I believe if you want to have it throughout all your cases, you need to have a modular system on board. So as you know, be on the top of any unexpected scenario that might come up. And this is my recommendation, all cases.
Can I comment on what constitutes high risk? Because beyond age and Euroscore, there are measures that we perhaps as a society should be encouraging users of this technology to record, because that is what characterizes high-risk cases. And by doing so, we will gain case series and beyond that, perhaps, pragmatic randomized controlled trials using different measures other than age and Euroscore. So I think measures of frailty should be looked at, and we perhaps need to consider a consensus as to the optimal measure of high risk.
Could I comment? I absolutely agree with you, Anastasiadis. I absolutely agree. But in particular situation now, we should targeting this group of patients now, because we switch to more complex cases. Sorry, but it's real life.
Mm-hmm. Okay, so no questions.
So
okay.
I think we move along.
Yeah. Okay.
And we make another great jump to India. We have Mr. Gupta joining us from India. He's a perfusionist there. And the topic of his talk is expanding MEAC beyond Europe.
Good morning to all. Hope you can see my slides and hear me properly.
Yes, we can.
Thank you for the introduction, and I convey my sincere thanks to organizers for giving me opportunity to share my opinion how to expand MEAC beyond Europe. I have nothing to disclose. During my today's presentation, I will share my opinion how to develop the MEAC in developing countries because MEAC is already in use in developed countries. I will also share some estimated data from India, which is collected from the reliable sources, which reflect the current status and potential of MEAC application in developing countries. Then I will end my presentation with the measures for its developments in developing countries. As all of us are aware, since the invention of conventional CPB, there is a lot of research is going to bring down the adverse effect associated with the conventional CPB due to unphysiological nature of conventional cardiopulmonary bypass. But after the extensive research in last 2 decades, there is absolute refinement in extracorporeal technology, and we have come across a physiological cardiopulmonary bypass system, that is MEAC system, which matches the cardiovascular physiology during the intraoperative perfusion. Because it contains closed system, biocompatible circuitry, reduced timing volume, the MEAC system maintains the integrity of the microcirculation. Here you have to understand, we all of aware with the fact that mix is a demanding procedure because of the awareness amongst the patients and thus improved surgical skills, and institutions are ready to offer the procedure to the patients. However, mix is done with MEAC system in Europe, US, Canada, Australia, and other developed countries. But still, it has not got that pace in the developed countries. Mix has its own benefits, better outcome and cost benefits because of shorter ICU and hospital stay, lesser transfusion associated complications. However, the MEAC system has evolved from type 1 to type 4 design. Still, lots of developed countries have not achieved that potential. In this slide, I will share the data from the India, which shows the potential of its use, and in overall, we have done 3 lakhs cardiac operations in last 1 year period. Out of this, 15 to 20,000 cases were done as a minimal invasive cardiac surgery. And we have total 300 centers all around in the India, and the centers are growing every day. And out of this 300, only 5% are doing routine mixed surgery, but they are not using minimal MEAC system. So if we say in developing countries, mix is in infancy period, then we have to understand that MEAC system is yet to born. So with this slide confirms there is a huge opportunity for development and potential for development of MEAC system in developing countries. There are challenges which hinders the use of MEAC system along with mix, because in developing countries there is lack of teaching and training facilities. There is no formulated instructions, protocols, or even the perfusion student curriculum does not have MEAC system lessons. There is lack of advanced simulation based technical teaching facilities, and for this complex system management, one need to be familiar with the through the simulation to gain the confidence and offer the safest MEAC system to the patient. Affordability to is the another issue. To if someone is interested to learn from the foreign by visiting foreign institutions, there is lack of global database to share the outcome with which increase the results, which increase the use of MEAC system in developing countries through the results and outcome. Affordability of the disposable and availability of the disposable is another issue. These challenges we can overcome through by a target-oriented approach. We can offer fellowship program dedicated to MEAC system, and support from industry and institution in this matter is highly desirable. Offering mentorship to trainees, those who are very well trained or executing the MEAC system in routine use, can provide mentorship to the trainees from the developing countries. and we can set a global database like ECLS database, a dedicated database to MEAC only. And this is very interesting point of my slide, MEAC friendship program. In India, during the pandemic period, government of India started a vaccine friendship program, and we distributed around 13 million doses of COVID vaccine to 98 countries free of cost under the vaccine Mitral program. So so the society can start a MEAC friendship program where from the institution from the developed countries offer their training and allow visiting of the trainee perfusionists or the team to visit their centers and have a live training. So there is a strong need of transferring effective technology from developed centers to centers of learning. And this team approach can be gained through taking the responsibility. So all the stakeholders have to take the responsibility. Industry need to provide financial support for educational purpose, although they are doing it, but mostly where there is business is running, not in the developed countries. In developing countries, there are educational seminars, trainings going on through the industry, and I'm very much thankful for the industry for that support. But they have to look for the developed countries as well. Institutions have to offer complete care or technology. Not means not simply offering mix to the patients. They have to provide a MEAC system along with for total care and optimum outcome for the patients and best result for the patient in favor. Clinician also, there should not be any hindrance or reluctance to learn and practice MEAC system, and they have to offer best to the patient. Similarly, society have to come forward, and MEACT is doing a wonderful job for this. And I'm delighted to hear from yesterday presentation of Dr. Polychronics and organizers that MEACT is making a huge library and books and all other database for and offering free of cost to the all around the perfusionists all around the world. And this is my final slide of my presentation. Expand in a zeal to expansion to exceal. Slide is at lighter note. Mix alone is awesome, but with MEAC it is unstoppable. Similarly, clinical perfusionist is strong to take care and learn, be confident, and offer the safest MEAC system to the patient. And with MEACT, it is unstoppable. I am interested to learn, share, and practice MEAC system. Please feel free to contact me. Thank you very much.
Thank you for a very nice presentation. Of course, we were all impressed with 300,000 cardiac cases in India annually. So let me start by asking you, how many members does the Indian Society for Perfusionists have?
We have more than 1,000 of perfusionists in Indian society, and this is an approximate cases load after the pandemic. During the pandemic period, it was lower, and nowadays because of some disposable issues, again there is some caseload is going down.
And you pointed out that MEAC is not yet implemented in India, so there aren't any systems running. Have you personally had life experience with MEAC, and where did you have that?
No, I have seen in the conferences, and I have not used it personally because of the non-availability of the venous bubble trap and soft shell reservoir in our institution. Though we do lots of MEAC with the conventional bypass, and even we tried with minimal circuit, means manually doing. Indian perfusionists are doing excellent job. If if the mini system is provided, disposables are supplied, we'll definitely use the MEAC system. On the other hand, I will also share the fact that India is the global leader in healthcare provider, and we provide healthcare service to all the patients from all around the globe.
In particular, I like the idea of a MEAC friendship program.
Thank you so much.
Because I was always convinced that we have to, those centers who are really experienced in MEAC, in order to get the technology out there and the knowledge, we should have training programs, even if it's short-term training programs for perfusionists coming in our centers, maybe for a minimum of a month or two if they're very experienced, and get them acquainted with this technology and starting to support them on site, at least with our knowledge. But up till now, I don't think any center has adopted that yet, but it's certainly a very interesting way to go, especially when we know that we have more than 300,000 patients in India waiting for the technology.
Thank you so much. I do agree with your point.
Any other comments from the audience? Maybe from the industry?
Mike, would you like
300,000 cases?
to give us some input on the condition in India and the need for disposables plus education? Because we, Rajiv, yesterday we tried to provide an answer with an online education initiative that we will launch with MiECT. So we will use online platforms and we will have a structured and integrated program of minimally invasive extracorporeal circulation education, accredited, we believe, from the major societies. And this will actually be a nice step in terms of globalization on education on MEAC, because definitely you need a lot of money, especially from India. They need a lot of money to come to centers in Europe and have proper training. And if you consider that there are 1,000 perfusionists, then it costs a lot. So what do you think that is the situation in?
Well, look, I think, and thank you for the presentation. The challenge that we have is really the availability within the reimbursement systems in some of the emerging markets to pay for this technology. I don't want to hide the fact that it's a real challenge. And in some cases, the biggest barrier for us in India, just as speaking as Medtronic, it has been that it's that that we struggle to be able to find even the ability for them to pay for the technology, and we see it progressing because 20 years ago we had the same problem in Turkey, and now it's not a problem, right? But we have to be patient, let the governments catch up with reimbursement. But like we have in some of the, that's why in industry we make a very specific differentiation now between developing, and emerging markets. The developing markets piece never really existed before this emerging markets concept really came out. So emerging markets for us means that a market that is already in a position to be able to have the kind of funding to pay for heart valves. And I'm not talking about locally sourced, because India is very self-sufficient. But one of the reasons why they don't have access to bubble traps is because there's no local manufacturer in India that has the capacity to be able to make them. So there is an element there that not the sophistication certainly of the procedures, but the sophistication of the funding and of the reimbursement systems to be able to support some of this technology is just not there yet. That doesn't mean that through we and other companies do a lot of donation, a lot of like the Medtronic Foundation exists specifically for these kind of options. But we just have to be patient. I like the idea of the friendship program, right? Because one way that industry can facilitate is certainly doing remote training or even being able to do on-site training.
Yeah, just to go back to the fellowship, to the friendship program, we do have a fellowship available in Canada and in Toronto. But I think if you think of the logistics, so you're taking staff away for a month at a time. I mean, we discussed this, right? You can come. Train on mini bypass or other perfusion techniques, but to be able to take somebody away from your staff for a month or longer, the logistics of that and the cost of that is still fairly high. So I don't know what the actual I don't know what the actual answer is. Is it cheaper to bring somebody over and do a fellowship and you're paying for their salary, you're paying for their their hotel, you're paying for their flight and everything, or is it cheaper just to send a team over for 2 or 3 weeks or something? So it's I just feel logistically it's very difficult for teams to, especially now with the shortage of perfusionists and shortage of team members, it's very difficult to bring people in, and there's just, I mean, I know there's a will, but people just can't do it. So that's the challenge I think we have, bringing that technology in.
Ravi, thank you very much for your presentation. Yesterday we discussed how to encourage anesthesiologists in the field of MEAC. Do you know if the discussion has occurred in India in the anesthetic societies about a more physiologic perfusion?
You're referring to me?
Yes, please. Do you know if the anesthesiologists are aware of a more physiologic perfusion system that is a potential?
No, the anesthesiologists and cardiac surgical teams are in a association with the different countries for the ECLS program, but not for this MEAC system use.
Okay, thank you.
Okay, thank you very much. So we need to go on with the next speaker. Thank you, Adrian Bauer from Coswig, and he's going to talk about the anticoagulation on MEAC.
Yeah, thank you very much. So I changed to the presentation. I hope you can see it now.
Yes.
Okay. Yes, great. Thank you. So thank you very much for the invitation, and let's talk about anticoagulation. So it's an old story. So it's a little bit younger than me that Bull established a system using a titration method to find out which is the best level for anticoagulation. Of course, with heparin, we're talking about a heparin anticoagulation. And if we are looking 40 years forward, then to the last recommendations, then we will find that recommendation here made in Europe in 2017, and they recommend here the EACTA and ESCTS to provide 300 to 600 units per kilogram heparin to anticoagulate a patient on the heart-lung machine, which ends up in an ACT above 400 for the most of the patients. And what the American says a year later here in that common recommendation between SDS, SCA, and MiECT, they recommend to have a clotting time over 480 seconds, which is the more or less old protocol. And also the recommendation then published 1 year later from the European board together with cardiac surgeons and cardiac anesthetists. They also recommend to have an ACT above 480. And that's what's recommended during the most of the guidelines published and used from us. So, but what we also know is, and this paper is almost 20 years old, 70 years, that that if you use a heparin management system, then we increase the dose of heparin, but we decrease also the dose of protamine, and that could be maybe associated with decreased postoperative bleeding. And yes, in the old days, we have big cardiopulmonary bypass systems with huge surfaces in contact with air, of course, and so on. And of course, now nowadays, and even with the MEAC system, we have completely different approach to the blood. That means there's no blood-air contact, no stagnating areas of blood in it, and the system is in the best case completely coated with heparin or polymer. So that's motivate us to reduce the ACT. In our clinic, we have had before more than 450 seconds, and then we go down to 300 seconds. And we also investigate the safety of that approach, with the aim to have a group, or we have two groups with a 300-second target and a conventional over 450-second target of ACT, using the HMS system for Medtronic to get that level. Then during that trial, we have a safety and efficiency part, and an efficiency part 2. That means we end up then with 100 patients investigated with that study. One thing I will absolutely bring in the middle of this talk is that you should use that approach currently only with a completely treated system, surface coated system, and you have to be aware that you have also parts in it where the blood is staying over a while. That means, for example, in our case, we use a Calafiore system, and you all know that the blood will stay there for 20 minutes. Therefore, we add heparin 10,000 units to the syringe of the cardioplegia system, and then we have a higher ACT in that system. So that's very important. Also, we use a heparin management system, hemostasis management system, which is very important. And I hope I know Mike is here, that we will have a new one in the next time coming up. We can discuss that. It's a very good system, and it's very good to control your anticoagulation, and even to have a good calculation before you start your anticoagulation, and not to give just 300 units or something. So the results was that we came down with not only with protamine, but also with of course, with the heparin doses, and we ends up then here in the middle with 18,000 units of protamine, which is very good. And that are the ACTs during that study. We investigate also the safety, as I mentioned before, and we have the thrombin potential measured. And what we have seen is that the anticoagulation with 300 seconds is completely the same, like with the old approach, with the high dose. So, and but on the other hand, we have much more better coagulation status of the patient, investigated here with thromboelastography. The clots came earlier, faster, and also stronger. So that means we expect that we have a reduced bleeding, and this was true. The bleeding amount was reduced by 400 mils, and which is a very good result. So we didn't see thrombus in the systems. We investigated all the systems, and there was no thromboembolic complication during that study. And this is in line with other studies investigating reduced heparin management, and they also find that this is safe and not associated with any complications. So, and also Bull already says in 1975 that 300 seconds he will never see any clots or something in the circulate. So it was more aspect of patient safety that they increased, that we have that high amount of heparin, and even with the MEAC systems we are able to reduce it, and then we can expect a better hemostasis and a positively influence of the post-operative hemorrhage as well. So that's our MEAC cases over the last years, and we changed the system in 2018. Then after that study, And we have now already more than 1,500 patients treated with that low anticoagulation strategy. And we didn't see any major advance or also not minor advance because of thromboembolic situations, never in the system or in the patient. So it's safe, and it can reduce bleeding amounts, and therefore I would say yes, it's a good approach, and it adds another positive effect to the MEAC approach. Yeah, sometimes it's less more, and yeah, I thank you for the attention and looking forward to the discussion. Thank you.
Thank you very much. So your level is 300 seconds, right, for the MEAC?
It is.
Okay. Any other clinic here doing MEAC with low dose heparinization here?
Yes, in Ancona we use the same protocol, and we use the HMS, and the results are very similar. We have analyzed our results recently, and we get a lower dose of heparin and lower dose of onprotamine with the system. But well, you know that the real clinical impact of this protocol, in my opinion, remains unclear. It may improve outcomes, but we have no evidence on that.
Yeah,
yet.
It's one aspect of MEAC, and that's what I want to say is this is one aspect, and all the aspects together then hopefully bring advantage for our patient. It's not only that strategy, but all the other things what we're doing with MEAC together, then it could be an effect.
Yeah, absolutely. I fully agree. A synergistic effect of all the components of MEAC may result in improved clinical outcomes. Absolutely.
Yeah.
Thank you. And yes.
Hello, Adrian Ashraf here. I have two questions. First of all, did you change anything in the frequency of measuring HCT since you implemented this lower target? Are you measuring more frequently? Are you measuring every 20 minutes? How was your strategy there?
Yes, during the study, yes, but now we are confident with that approach, and we are back to the regular measurement, not every 20 minutes, once per hour, or if we have a feeling, or you know, sometimes they have not enough AT3, and then we of course increase the frequency, but normally it's the same approach.
And another question, I think your initial study was limited to CABG patients, so now you're targeting 300 in every patient who's done on a MEAC, or is that still limited to CABG?
No, it's then also for all the MEAC cases now.
Yeah.
Great presentation, Adrian. I just wanted to follow up a little bit. So do you do any conventional? So your conventional bypass, you're still using 480 target, or you lowered that as well?
Yeah, we still use conventional bypass, and in that cases we have done a different. We use the old protocol. Yeah.
So you also measure with the HepCon your heparin concentration. So are you running just ACTs? Are you looking just at ACTs 300, or you're looking at ACT and heparin level at the same time? Because I kind of believe there's a big difference if you're just running ACT, but if you're running ACT and heparin, so are you running ACT greater than 300 and heparin levels greater than 4, or which do you treat? Which do you not treat?
Yeah.
Do you know what I'm saying?
Yes. I guess I understand what your question is. The best cartridge from the HMS is the heparin dose response. This cartridge is very good. So if the HepCon says you need 1.5 units per mil to get a 300 of ACT, you will get it. So, but then the problem starts with the hemodilution of the patient and the changing during the operation and so on. The next cartridges using the gold one, and you know all that things with the protamine in it. A little, then your calculation of the blood volume of the patient don't fit to the situation during the operation, and then the differences are there. So for that reason, we mainly doing then also an ECT or only an ECT, and at the end we make the red one cartridge to calculate the protamine dose. So it's a mix of both approaches, and I can repeat or will repeat. I'm really looking forward to a new HMS system, and hopefully we will get it, and then probably we have a one that also measured during the operation stable, during the perfusion.
Okay, so my understanding is you're not measuring heparin heparin concentrations during the whole pump run, right? Is that
during the whole pump we more stick to the ACT. Yes.
Oh, okay, just at the beginning. Okay.
Sorry, Cyril. Actually, we've got one of the centers that helped us develop the HMS concept protocol in the room here. So maybe if the team from Angers would and Dr. Ed could say something.
Thank you, Dr. Bauer, for your presentation. I'm chief resident in Angers, and we actually have the optimized extracorporeal circulation. We don't use centrifugal pumps, but we work in closed circuits, and we have roller pumps. We have an added reservoir for the venting of the patient. And we use objectives of 250 ACT for cabbage, 350 for every other surgery, and we use the HMS daily. So my question is, for your cabbage patient, it's 300 your objective, and for other type of surgeries also, you did not try to lower your objective for the closed heart surgery yet.
Yeah.
Okay. Thank you.
Okay. Sorry. Yes, Philip.
I think we have to be careful when we are discussing this, because there are several aspects. First of all, ECT will differ depending on the activator we are using. And very often we do not really mention which activator was used. A second question, I think, is the important difference between measuring concentration and measuring the inhibition of 2A by the heparin. And actually what we are interested in is both the effect on anti-10A and on 2A. So in our institution, for example, we actually measure 2 by using viscoelastic testing. And then you can see that you can go extremely low, as was already mentioned by the previous commenter, that you can go even to 250 as long as you have sufficient inhibition of your 2A. And I think we should probably change a little bit the way how we look to the anticoagulation during our procedures.
Absolutely right. And what we are doing, if we going to the border, we leave the safety area. So to have a full anticoagulation, you will be safe. But if you are going down, you have to be careful and more clever and more intelligent approach, like what you mentioned, Philip. I absolutely agree. Yeah.
Okay, thank you. Okay, so thank you very much, and we go on with the next speaker.
So we move on to this next speaker, Pascal Sternieri from Hasselt, Belgium. He is a perfusionist, and they do a lot of minimal invasive cardiac surgery in their center. So he has an extensive experience on the combination of both. And the topic of his speech is application of MEAC in minimal invasive cardiac surgery. Unfortunately, he's quite busy at the moment. He has something parallel, and he has a pre-recorded presentation.
Hello, good morning to you all. If you're seeing this video, I will not be able to join you live in the session because I will be at work in theater. My apologies for that. I would like to thank the organizers for giving me the chance to talk about the application of MEAC in minimal invasive cardiac surgery. So just to point out, last year we did around 800 minimal invasive cardiac cases, and we all did them with type 3 or type 4. So if we are talking about MICS and MEAC, we always talk about a certain strategy. It is a team approach, and in my opinion, also using MEAC, you are forced using a certain strategy, and in my opinion, it's a strategy that works. And the strategy is also training and education for all the members of the team. So all the stakeholders, they need to be trained, they need to be educated in minimal invasive cardiac surgery and minimal invasive extracorporeal circulation. So as a perfusionist, you all also need to know every step of the surgery, you know the critical points and where you need to be aware of. That also is safety comes in. In my opinion, that's the most important thing. We work with bubble sensors, level sensors, aortic clamp. So if there is an issue you can handle, you need to have backup mechanisms, safety mechanisms. Even if you have, let's say, once in 2 years you have an issue, there always will be people standing at the sidelines and tell you, I told you so. So be aware, always have backup mechanisms. Also in the strategy is cell salvage, not only for the evacuation of air in your mini bypass system, but also for separate suction. So we have one sucker line that goes from the table to the cell saver. Coating, I find also very important. We are tip-to-tip coated. Nowadays, we are glad if we get another venous cannula due to the back orders, but normally it's coating tip-to-tip, and also the cardioplegia. The solution, it's also a certain strategy, but I talk now about the solution. We are using the mini bypass systems, and we adapted a solution from Amsterdam. We modified it a little bit. We have a mixed solution, 3:1, so 3 parts of blood, 1 part of crystalloid, 1 single shot, also very important if you're doing endoscopic surgery. It's sometimes difficult to repeat it every 20 to 30 minutes. So with this cardioplegia, it's an intercellular solution. We give 1 single shot and we go up to 2 hours. So you dilute the patient with 200-300 mils, which you can easily handle within your circuit. So just to point out the evolution in MICS from the aortic surgery in our center, we started conventional AVR. Then we did a partial sternotomy AVR with a pulmonary artery vent. And then afterwards we started to the totally endoscopic, with a small thoracotomy, but a totally endoscopic approach with a pulmonary vein vent. So the switch from the pulmonary artery to the pulmonary vein vent was also a switch in systems from the type 3 to a hybrid system. Because in a pulmonary artery you don't have any air, you can drain it directly into your venous line or through a drip chamber or a venous bubble trap. In a pulmonary vein vent you have some air, so you need to go through in our situation an hard shell reservoir. So safety on MEAC, what you see here is we have bubble sensor. We have a 1/4 bubble sensor below the drip chamber from the root venting. If there is some air there, you have the air pressure control in your venous line. If there is an air, it will be automatically evacuated with a level sensor on. If there is a massive air, your air pressure control can't handle, so you have your level sensor and it will trigger the clamp and it will close, so it will not go any air to the patient. Also in the venous line we have quick connectors. If you have a major issue, you can also put a reservoir in very easily. You can click it in and you can go on a conventional system. So in the daily practice, as I mentioned, we have a type 3. So a type 3, so we can store blood in the back. And this is mainly used in closed procedures, closed heart procedures like an endoscopic CABG or an AVR if you're using a pulmonary artery vent. So this is also perfectly possible. Then, as I mentioned, we have also quick connectors, so we can put a reservoir, and hard shell reservoir in if we have major issues. And then we have also vacuum source to drain the blood to the reservoir, and afterwards is the mini system the revolution pump of the mini system, it ranges from the reservoir and goes to a patient. So this is his worst case scenario. Then afterwards, if we do open heart surgery, let's say a valve surgery, we need to open the heart, we use a hybrid system. Hybrid system is where the venting is drained to the front of the reservoir. It goes down to two small tubes, and then you can add it blood back because you lose volume. You need to give volume back for your steady state during the procedure, and you can give it back or by opening the clamp, the tubing clamp, or you can put an EVO, an electronic venous occluder, also easy to handle. Also in that MEAC approach, we have the retrograde autologous priming. So we try to get rid of the crystalloid priming and we push it to the cell saver, or you can push it to the bag, depending on. So you see, first we put a clamp and an oxygenator, and then we open the clamp to the reservoir, to the cell saver, so you can push the crystalloid priming to the cell saver. Just looking for the clamp, you open the clamp and blood comes down. Voila, and goes to the cell saver. Then afterwards we start with the antegrade autologous priming, so it's practically the same. You open the clamp to the cell saver, you go on bypass with a closed arterial clamp, so you push all the priming to the cell saver. And then by opening the clamp, you can go on bypass. You see here, the connection is done with the cannulas, air-free connection. You see the coloring of the venous bubble trap now. Then afterwards, it goes to the pump head. And then you also see the coloring of the oxygenator in a few seconds. And there it is. You always keep your eyes also on the blood pressure, because it's not always possible to get a full retrograde and antegrade autologous priming due to the volume state of the patient. And then the next step is start the CBP. Just opening the arterial clamp and you go on bypass. Checking here, opening manifold, start the timers, and then afterwards you look at, because we do all fem if it's possible, depending on the shape of the vessels. Of course, we do fem cannulation. So most of the time we have some smaller cannulas. So depend on so be aware of your arterial line pressures and also your venous line pressures. Also very, very important. So to conclude, it can be equally safe as conventional in MIECs. Just know your system, you know the procedures, you know what the system needs to have a safe procedure. Also, it's a difference. And 10 years ago, Dr. Yilmaz came and he was skilled in minimal invasive cardiac surgery. Afterwards, there were new members in the surgical staff, and also they had a learning curve. So also that becomes very important if you're doing MEAC system, because like putting a clamp in an endoscopic cabbage, you can also harm the pulmonary artery, or by manipulating you can the right ventricle and so on. So keep in mind, keep your backup mechanisms there. And then MEAC, it is a strategy. Also, it's the mix, the advantages of MIECs and the advantages of MEAC. It is perfectly possible, but its communication is key, in my opinion. There, all the stakeholders need to be aware what you are doing and what is the next step, and then you can safely perform MIECs and MEAC. So thank you very much. My apologies again for not to be able live in the session, but if you have some questions, you can always contact me afterwards or catch you later. Bye-bye. Thank you very much.
So it certainly was a very interesting talk. Serdar, you said yesterday that you work in a very large center with 4,000 cardiac cases, and you said that you were implementing now MEAC in MIC for several years. So what do you do differently?
Well, it's really been a difficult process. It was not as easy as Pascal told today. So especially we had very difficulty in the early cases for the drainage of the heart. So because you're doing peripheral cannulation, and we use TE for all cases, minimally invasive surgery, to position the cannula. We always have the drainage problem. So we now use, for example, one from periphery and one from central, so double venous cannula, and also always need to TE and with an experienced anesthesiologist, because during the surgery something may happen, so dislocation or any other problem. So we need to repair those problems with the aid of the anesthesiologist helping us. And of course, the bleeding sometimes may be a real problem. And we still use full dose heparinization. We didn't change anything. But here, I think Ignacio Condelo also is a very experienced perfusionist to use minimally invasive on MIECs. We can also ask his feedback.
Yes, Professor. Thank you so much for your observation. Good morning, everybody. And we use the minimal invasive extracorporeal circulation in particular for aortic valve replacement. And our nadir for assessed the volemia and the drainage during the procedure is the use of transesophageal echography and central venous pressure to assess the volemia during the procedure. We use a double cannulation in jugular vein and in femoral vein to assess the good drainage during the procedure. And I think today that the major limitation, in my opinion, there is no nadir present in literature how to manage the volume in relation to the patients and the body surface area before the procedure. For example, the use of Trendelenburg position, anti-Trendelenburg position, the use of soft shell venous reservoir, or the use of the small vasodilatation. This is the problem of the minimal invasive cardiac surgery today. How we use the different strategy, in my opinion. Thank you.
So let me ask you another question. So what kind of cardioplegia do you use?
I use Calafiore, blood isothermic cardioplegia, and St. Thomas solution. Because today we have a diffusion of the nido cardioplegia, and I believe that is in contrast, in particular for the small patients, for oxygen delivery. I see that the patients in my past experience that use the nido have a reduction of indexed oxygen delivery. And I believe that for a minimal invasive approach, in particular for the patients that have a low hemoglobin concentration, for in high risk of low oxygen delivery, the blood cardioplegia is a good solution. But the problem is that the time of the surgery. You selected the cardioplegia in relation to the time of the cross-clamped extended of duration. In our clinical practice, we have 60-70 minutes for implantation of standard aortic valve and 30 minutes for sutureless valve.
I just wonder if I might ask a question as well. One of the issues that we had found, particularly when there's issues not infrequently with poor venous return, has been the use of NIRS to detect, particularly when the SVC cannulas have been malpositioned. And one of the things we've been finding that helps to focus the mind on the importance of the venous drainage is when we start to see cerebral desaturations, because often the perfusionist will be somewhat unhappy with some of the venous return, but as the procedure's ongoing, the surgeon's more focused on getting the operation done. But when we see the NIRS is going down, we've now got a risk of cerebral ischemia. That tends to be really focuses attention on the importance of the venous drainage. And I wonder, are most centers using NIRS as a routine now when we're doing these types of procedures? Is that a commonality?
We routinely use.
Yeah,
yes.
I think that's very important because we've seen a number of these, and that's been the first indication. Brain sets start to go down, and then we're looking at the cannula malposition. Yeah.
Okay, so thank you very much. So we go to the next speaker, our previous.
Excuse me. Can I just ask a question to the specialists and the panel? Regarding the cardioplegias that you use, do you often require to do hemofiltration at the end of your surgery, or is it, how do you manage the excess of volume that you input in the patient with the cardioplegia initially? Thank you.
Thank you. I respond to you. Depends of the technique, in particular for crystalloid solution. For example, the nido depends of the level of hematocrits of the patients and the other characteristics. I prefer use the ultrafiltration or the stimulation of diuresis during the procedure, for example. This is the only solution, but I think that is in contrast the use of crystalloid solution. The other solution is the aspiration in the venous sinus venous coronarius with the external aspiration during the procedure. I believe that is really solution for reducing the hemodilution.
Okay, thank you. So we now go to the next speaker, our previous president, John Murkin. He's going to talk about the prevention of delirium in cardiac surgery.
Good. Yes. Well, thank you very much again for the opportunity to participate both in the society and in this meeting. And if we can have the first slide up, that would be most helpful. Here we go. And I did have to actually change the title somewhat. I don't think we're going to be able to prevent delirium, but we can perhaps make some efforts to minimize it, because as I try to show, it seems to be quite multifactorial. And as we're aware, delirium is defined as a fluctuating alteration of attention, consciousness, and cognition, the decreased ability to focus and to sustain or shift one's attention. And one of the important considerations is always to rule out some treatable etiology, particularly occult infection, classically bladder infections, even dental abscesses, or particularly patients that present with pre-existing renal insufficiency, hepatic insufficiency, or other exacerbations of other comorbidities. Can be delirium can be one of the early manifestations. So important when we see these patients post-operatively to try to rule out these more treatable causes. There's been a variety of scoring systems used, and I think most institutions now, because of the focus on delirium, because of the implications of patients that develop postoperative delirium, I think in most institutions now there's some survey using these various types of screening scores. And I think the CAM-ICU is one of the ones that's been most frequently used. There's been a number of focuses now on the implications of patients that do experience postoperative delirium. And this was a recent meta-analysis, but just showing that patients that experience postoperative delirium have a significant increase in their mortality rates compared to those patients that do not have this type of postoperative event. It's also associated not only with acute increases in morbidity, but there's also a significant association with rehospitalization. So it's a marker, again, for systemic issues that may manifest. And one of the other associations has been made that patients that do experience postoperative delirium have a much higher incidence of both early and later cognitive decline. So patients that have had delirium often demonstrate decreased performance on a variety of cognitive testing. And there's also been an association with early onset Alzheimer's and related diseases. And as mentioned, the mortality rates are increased. So delirium is a significant problem that has potentially longer lasting effects than the immediate management of the patient. So associated with an increased probability of death and readmission to hospital. When we look at the types of patients that are susceptible to this type of phenomenon. This is one of the more recent, again, meta-analyses looked at 14 studies with over 13,000 patients, and predictably patients that are older, patients with lower ejection fractions, those with a history of cerebral vascular disease or concomitant carotid stenosis, diabetic patients, and those patients that have pre-existing cognitive impairment or depression are particularly at risk of these types of postoperative complications, and particularly patients that have a prolonged or a delayed extubation times or prolonged stay in the ICU, probably as a marker of other comorbidities. These patients are obviously at significantly increased risks. And one of the somewhat more disappointing findings has been there was some preliminary evidence that patients on preoperative statins had seemed to have some protective effect against postoperative delirium, but in further studies, this hypothesis has not been sustained. So when we start to look at some of the etiology of the onset of depression, it is clear that there may be several types of phenomena that give rise to this, such as cerebral dysautoregulation. And my own bias, I think that this is one of the underlying causes. And there may also be a role of various pharmacologics, particularly the use of benzodiazepines. So when we start to look at some of the aspects of cardiopulmonary bypass, we were very interested in looking at microcirculatory vasoreactivity using an ischemia reperfusion challenge, in other words, a blood pressure cuff, and using tissue oximetry to measure both the desaturation and, most importantly, the reperfusion, the slope of the reperfusion curve, and then the hyperemic phase, which is the little bump above the arrow. So looking at how, can't get that thing to go up. So we have normative data, and then we can use this to look at patients at various intervals, both during the procedures and after the patient is weaned from the heart-lung machine. And so what we've found is that in a small study, we could show a progressive decline, which is the white bars in the center, in the vasoreactivity. So the microcirculation is quite sluggish. during and progressively deteriorated with the duration of bypass. But in this group, all of the patients with the reinstitution of pulsatility after weaning from bypass, the vasoreactivity responded or returned towards their normative values. One of the fellows that was working with us is in Seoul, and they have a very large beating heart practice. And in this study, which hopefully will appear momentarily, we also looked at the correlation between this peripheral measure of vasoreactivity, also looking at sublingual microcirculation, and showed that there was a correlation again between some element of capillary sludging and loss of perfusion of capillaries progressively during non-pulsatile bypass that was reduced in patients with pulsatility, and there was a correlation between the minimization of their normal vasoreactivity and evidence of this microcirculatory sludging, which was significantly different between the pulse and the non-pulse. So we think there's some factors during cardiopulmonary bypass that can influence the microcirculation and may give rise to some of these postoperative complications. When we looked at patients who undergo non-cardiopulmonary bypass, in this case OPCAB procedures, we saw a somewhat similar phenomenon in that when we looked at patients in whom they had a progressive reduction in vasoreactivity and the day after the operation, so their microcirculatory reactivity had not returned to normal. These patients had a significant increase in postoperative complications and length of stay in the hospital. So it's clear that it's not just the heart-lung machine that can produce these microcirculatory disruptions. And again, I think it's part of this inflammatory response that's giving rise to this microcirculatory aberrations. And I think this is part of the consequences, a variety of end organ dysfunctions, some of which may be exposed as delirium. And so this is, again, a more recent study using a somewhat different technique. They were looking at a form of I believe it's plethysmography, and again, an ischemia and reperfusion challenge, and showed, in this case, they were focusing very particularly on CNS outcomes and delirium, and showed once again that there was a correlation between impairment of the vasoreactivity of the microcirculation and the occurrence of various types of acute brain dysfunction. And even this study was looking at cerebral hyperperfusion. And I was struck by a couple of things in this paper. Firstly, I was surprised to see that they were using a pH stat management, since we know that the exogenous CO2 is a direct cerebral vasodilator and tends to disrupt cerebral autoregulation. And so what they found in this population, using transcranial Doppler as a measure of flow velocity through the middle cerebral artery, was that in patients in whom they had a significant increase, which I believe was on the order of 10 or 15%, of flow velocity through the MCA. So in other words, these patients had an experience of hyperperfusion that in this again was associated with postoperative delirium. So I think what we're seeing is that the integrity of the microcirculation, I think, is one of the crucial elements in either preserving or disrupting end organ function. What can be done about these issues? These are just box plots showing again that there's a correlation between the amount of hyperperfusion occurring, the extent of hyperperfusion, in other words, the increase in MCA flow velocity, and the duration were significant factors in the occurrence of postoperative delirium. This was, again, very similar to the results shown by Hoag and colleagues at Johns Hopkins, where they were using NIRS to determine the upper and lower limits of the autoregulatory parameters in the brain, and found again that in patients in whom they became hypertensive, even postoperatively, if that was outside the upper bound of their cerebral autoregulatory limits, that again, this was associated with postoperative delirium. So a fair amount of evidence then indicating that the brain microcirculatory integrity is crucial for preservation of function. I'd just like to share some of the preliminary results. One of the other very strong associations with postoperative delirium has been the administration of benzodiazepines. So I'm just showing some of the preliminary data. Jessica Spence is the primary investigator on this multi-center trial. We were the site investigators at our institution. And she started off with a survey of anesthesiology practice, indicating that there's a wide variety of practice amongst various anesthesiologists as to the administration of benzos. Some respondents give everybody benzodiazepines, and others use it very sparingly. So it seemed to be a somewhat random occurrence whether or not the patient receives it. So this study was framed as a pragmatic study, which was very important because these are both relative standards of care that the central REB enabled us to waive consent. So we didn't have to get specific patient consents to enroll them in this study, which greatly enhanced the recruitment and participation. So where we are currently, there were 20 sites in Canada, and so far we've recruited nearly 20,000 patients. So we've pretty much gotten to the anticipated sample size. And it's expected that we're starting to analyze the data. So hopefully we'll have a definitive result as to whether or not benzodiazepines in particular are associated with this type of adverse consequence. And our incidence of delirium is pretty consistent with what we've been seeing in the literature, with about 15% of patients overall having experienced delirium in this very large study. So I think there'll be a lot of very useful data comes out of it, in addition to the role of benzos in potentially precipitating this, but also just looking very rigorously at the incidences of delirium and all of the secondary consequences, duration, and associations with other adverse events. So hopefully that data should be getting presented sometime later this year. And we will again, be able to draw some definitive conclusions whether or not the routine use of benzodiazepines should be avoided. There's a lot of animal data, again, indicating that this is associated with a significant decrease in GABA receptors. And as you know, this is the inhibitory pathways in the brain. So there's a concern that chronic use of benzodiazepines or in susceptible patients, particularly those that are older, even single administration of high-dose benzodiazepines can be associated with these secondary effects on receptor downregulation and potential hyper excitability in the brain, which can precipitate a variety of secondary consequences. One of the newer areas that is becoming clear in the emerging literature is there may be some role for dexmedetomidine, and there's now been several studies, both single center as well as, in this case, a meta-analysis, which does seem to suggest that the use of dexmedetomidine, both in contrast to benzodiazepines, but also in one of the studies, they compared the use of dexmedetomidine for post-op sedation compared to propofol. And in both instances found that the dexmedetomidine group had a significantly lower incidence of delirium. So this may be a potential beneficial administration moving forward. So I think in conclusion, we can say that there are certain patients that are at increased risk, those that are older, low ejection fractions, pre-existing neurologic impairment, diabetes, and long pump runs. And I think all of these things to some extent may again reflect some impairment of pre-existing impairment of microcirculatory vasoreactivity, particularly diabetics, and that one should strive to preserve the baseline hemodynamics. One of the other observations have been made in several studies that up to 20% of patients presenting for cardiac surgery have no discernible intact cerebral autoregulation. So a significant number of our patients are presenting who have some failure of cerebral autoregulation, and these patients are particularly susceptible both to hypertension and hypotension, both factors which have been associated with postoperative delirium. I think certainly in our practice, my practice, I've not used benzodiazepines other than for this particular study. So I think one can pretty well advocate to avoid benzodiazepines. And again, moving forward, there may well be a role for dexmedetomidine to try to minimize some of these occurrences. So I'd like to thank you all for your attention. And if there's any questions.
Thank you very much. So delirium is also the main targets of the ERAS protocols nowadays, especially in the preoperative preparation. We switch from benzodiazepines to gabaline, pregabalin, for example. And during the surgery, we follow the non-opioid anesthesiology. So what do you think about non-opioid way of doing the cardiac surgery?
Which way, sorry?
Non-opioid, using no opioids during the surgery.
Yes. I think the whole practice of anesthesia is evolving. And I was intrigued with the use of blocks in your patients to decrease narcotic usage. In fact, I reviewed one of our papers from many years ago when we were doing paravertebral blocks for that very thing. I think the more we can avoid the use of any of these fixed agents, the better off the patients will be. And I think the other component I think came out, I think that was your presentation, Serdar, was the nutritional assessment preoperative. I think a number of our patients come in suboptimal, optimally prepared. So I think there's a whole range of strategies that we can employ.
So what do you think about the preoperative diagnostic tests, psychiatric tests or psychological tests to detect early delirium?
I think they're of interest. I'm not, we certainly have been doing that in a number of study contexts. Whether one should, it probably wouldn't be an unreasonable thing as to establish sort of as a benchmark to see what the overall impact of hospitalization with surgery, bypass, all of that kind of stuff is, what the actual impact is on post-operative cognition, and whether patients do or have a significant decrease in their cognitive performances. Our more recent data would suggest that this issue seems to be decreasing in our post-operative cases, and I suspect that is in part a combination of over the decades, switching away from bubbles to membrane oxygenators, less gaseous microemboli, more use of arterial filtrations, difference in anesthetic medications. I think all these things cumulatively are leading to better overall outcomes. But I think doing preoperative, if you had an institution where you were routinely assessing pre and post-operative cognitive performances, I think that would be a very informative thing to do.
Thank you. Any questions? And again, from the panel on.
Okay. Can I make a comment on that?
Yeah. Yes.
Because in our heads, the implementation of ERAS protocol results in a significant lower incidence of postoperative delirium. We have just published on that. And I think it's a combination of low-dose anesthesia, but also early extubation, early rehabilitation therapy, and mostly early patient-family contact. In our hands, it results in a significant lower incidence of delirium in patients undergoing minimally invasive valvular surgery.
Thank you. And Mark, do you want to do any comments on as an anesthesiologist?
John, thank you very much. I just wondered what your views are on the challenges of detecting hypoactive delirium, and whether you've got any evidence that hypoactive delirium is as harmful to patients in the long term. Really, I'll leave it at that.
No, is the short answer. I know you can have hyperactive and hypoactive delirium, but I haven't seen any particular breakdown showing that either manifestation has longer term implications than the other. So yeah, I can't really comment on that. Sorry.
Can I ask a question very quickly?
Please.
Yeah. Thank you, Dr. Merkin. My question is regarding hyperperfusion. You presented an article that talked about hyperperfusion, and regarding obese patients, very high-weighted patients. Do you think that the calculation of the output of the CPB on the surface, the body mass surface, we're pushing it because they're very heavy? Do you think that this might have an impact on the perfusion of the brain and on the outcomes? And should we adapt?
Yes. I think that's a very good question. I think one of the things that, that's why I say I was quite surprised at the group that's using pH stat currently. I think one can make an argument in pediatric heart surgery, but I think for adults, it's pretty well established that if you use significant amounts of exogenous carbon dioxide, that we vasodilate the brain, completely defeat cerebral autoregulation, and leave the patient very vulnerable both to hypo and hyper perfusion. So that's the backstory. What we tend to do is try to calculate the lean body mass. So yeah, we have a number of very obese patients. But I think our perfusionists, we're using the mixed venous oxygen saturations as a primary guide to the that plus NIRS to determine that we're getting adequate tissue perfusion without hyperperfusing the patient. But I must say that when we years ago looked at our patients with alpha-stat, we found that the cerebral blood flow was quite constant, independent of pump flow or mean arterial pressure over a very wide range, because we were preserving the cerebral autoregulation in these patients, with an asterisk that both the large studies from Hoag and his group and a study we did a little while ago, we can show that about 20% of patients seem to have a significant impairment of cerebral autoregulation, so diabetic patients in particular. And so I think in those patients particularly, we're very concerned about trying to preserve. We use the patient's baseline hemodynamics as our sort of our guide to select perfusion pressures during the pump run.
Thank you. So then let's go to the next
I think
speaker.
we're running a bit late, so our next presenter will be Professor Polychronos Anatonitsis, Secretary of the MEACT and one of its most active members over the last 9 years. The topic of his talk will be mitral valve surgery on MEAC.
Okay, thank you, and welcome to all our guests. I will be very, very brief because we have discussed actually about most of the issues raised during valve surgery, and especially mitral valve surgery on minimally invasive extracorporeal circulation. So, progressing with the presentation, I would just like to stress that mitral valve surgery, as you can see, it's an advanced phase surgery during MEAC strategy, so you need to have a type 4 a modular circuit to do it properly. So the prerequisite for doing mitral valve surgery is having the type 4, the modular circuit with an accessory standing by component we've discussed, either with pre-connectors or as connected to the circuit before and ready to implement with clamping. This is our modular prototype MEAC system. We have discussed a lot about how to vent and how to recirculate the blood collected to the sterile reservoir through the cell saver back to the patient. So we have this circuit offers advanced air management, air handling, and volume management capabilities. And Apostolos could ascertain that it's 100% safe and 100% effective in performing all types of cardiac surgical procedures. So, which are some procedural tips and tricks that the surgeon mainly should know during mitral valve surgery or minimally invasive extracorporeal circulation? Bicaval cannulation. Just while looking at a short video, choose the free wall of the right atrium, avoid large holes in any case to avoid air entrainment to the circuit, single tie to secure the cannula, and of course, establish always airtight connections. Single tie to secure the cannula is because you may need to remove the cannula in order to establish optimal flow. And when we're putting tourniquet around the caval veins, meticulous dissection around the caval veins in order to avoid inadvertent holes, use a large and a small tape, so 2 tapes for each caval vein. The large tape is snared distally, while the small tape is snared centrally. Flow, Apostolos is always checking the flow at both caval veins so as to determine the optimal flow. You actually heard that Philippe de Sommer is very, very keen on establishing the proper ratio between the vessel diameter and the cannula diameter. This is important in securing optimal flow. Proper positioning and the proper choice of the venous cannula is crucial in having the optimal flow during minimally invasive extracorporeal surgery. So another step is the approach. In our institution, we have converted from the left atrial to the transseptal through the right atrial approach. So the use of transseptal approach through the right atrium minimizes kinking of the cannula. As you can see in the picture, preserves, it establishes a pretty bloodless field. It preserves circulatory flow, reduces suction episodes, and as you can easily see, within the next few seconds, it provides optimal exposure. So we shifted from the left atrium approach to the transeptal approach. And these are the final steps. We use a pledgeted, we use the aortic root vent plus a right superior pulmonary vent for venting the heart. And when the right atrium is open, you can use directly retrograde cardioplegia infusion, and always remember to use the aortic root vent to suck the blood that is coming from the coronaries. With this technique, we've done 48 patients with a variety of mitral procedures. It's 100% feasibility and technical success. So the 1 million question is, when do you need to open? So we opened the circuit in 2 replacements, 1 reoperation, in 1 repair, 2 combined procedures, and 1 replacement plus CABGs, double valve, another double valve with tricuspid. So actually, we opened in 8 out of 48 patients. So the rate was almost 17%. And I would like to stress that if I can go back, it seems that I can't. So my main message is that the time that the circuit was open was about 50% of the total CPB time. So actually the operation was performed with a 50% closed circuit. The same results actually have been accomplished by Sraf El-Ezawi, who's also performing mitral procedures on MEAC. I think he had minimal percentage of conversion to an open circuit. So the operation is performed with a type 3 circuit all of the time. And following these steps and having a modular circuit that we consider is the state of the art in perfusion, modularity establishes and secures safety. And by implementing all the strategy that we have discussed for the last 2 days, technology plus physiology plus teamwork plus strategy, this establishes and this offers the best outcome in cardiac surgery. Thank you very much.
Thank you very much, Polychronos. It's obvious that this is not an issue. Mitral valve surgery is no longer an issue for MEAC. However, we totally agree this is something for a type 3 to 4 system. A type 2 system should not be used in this kind of procedures.
This is the message.
This is the main message.
Yeah.
You need, whenever you push beyond aortic valve surgery, you should go for a modular system that gives you all the capacities. It's the same that Pascal said. You have to have a backup system. You have always people on the sidelines who will always tell you this was prone to, any catastrophe was prone to occur sooner or later. So you have to have a type 3 or 4 system at hand. And I think this is the main message that we can all agree upon.
So shall we go?
Sorry,
Yeah.
Polychronos, have you looked at the actual results and compared the patients, the 20% of those patients, like what the actual outcomes are compared, like, blood transfusions, like in any difference in
Yes, yes, we have studied that the patients that have been converted to an open circuit definitely require higher transfusion due to hemodilution. So this is an interesting finding, and also they have a higher, let's say, lactate levels. Not very much statistically significant, but they have higher lactate levels, and we need more blood in these patients. The final outcome in terms of major adverse events is not different. There's no difference. And we are very, very proactive in converting the circuit to open. So if there is any issue, convert to open, fix the issue, and come back to the closed circuit. There's no need to have to compromise flow and to compromise perfusion. Yeah. This is the message.
Okay. Yes, Prakash.
Hi. Thanks. Thank you, Paul Collins. That is very interesting. And I think I must congratulate you. I think all we need to do is persist in this endeavor. As you said rightly, the message is at least a type 3, maybe 4 circuit, and continue to persevere if you need to, open and close. But I think we will, as we persevere, we will see more benefits as time passes, because it's all about immediate recovery, post-operative recovery, rates of atrial fibrillation, rates of bleeding, rates of post-operative delirium, as we had such a nice discussion this morning just before. And I think it is really a case of perseverance to try and achieve as much as we can. So my congratulations to you. And I feel very strongly that it's the perseverance that will give us more benefits in due course. Thanks.
Thank you. So we are now going to the last speaker of the session, and it's my honor to introduce one of the most distinguished Turkish scientists based in Netherlands, Can İnce. He is going to give his lecture about microcirculation, and we are very much curious to listen.
You're mute.
Can you hear me?
Yes.
Okay, now the next thing is to share my screen. That's going to be the next challenge here. Can you see my screen?
No.
You can't see my screen. Okay.
Yes, now we can see.
You can see the screen?
Yeah.
Great. Okay, off we go. So I want to extend my thanks to Professors Anastasiadis and Antonitsis for their kind consideration to include a physiologist in this very interesting conference on MEAC. And I was asked to give some insights into where we are now regarding microcirculation in cardiac surgery. And I will focus my talk on 2 issues, both of which are relevant to MEAC, in my opinion. One is the fact that you need to use less fluids and the adverse effects of fluids in cardiac surgery. And the second is the cytokine load that one gets under normal CPB, and that this might also be reduced by MEAC. So off we go. I have a company called Active Medical. We have now produced a new microcirculation device called the OxyCam. I will present some of that. And I also received speaker's fees from the company called Cytosorbents, which I will present also some results of. Most importantly, I'm a physiologist. And I hope with this presentation to present to you some of the underlying mechanisms that are really going on during your surgery and anesthesiological procedures, all of which are going on, which affect many of the clinical issues which have been talked about in this conference up until now. So I think the biggest thing that's really missing at the bedside and during surgery is an insight into what actually all is going on at the levels of the tissues. It's to introduce physiology at the bedside, because it's my opinion that only if you have insight into the mechanisms that you can alter it and deal with it. So looking at the microcirculation with these handheld videos, microscopes, and here at the bottom one is the latest version, you can see in great detail at a cellular level what's going on during the various procedures. The most accessible area is underneath the tongue, in the so-called sublingual triangle, and to date more than 600 papers have been produced using this technique, mostly in the field of critical care medicine and in perioperative medicine. If we look at practically all the guidelines regarding shock, hemodynamic monitoring, fluid therapy, all is really focused on the ability to influence microvascular flow or tissue perfusion as it is. But yet there is no direct bedside technique available which directly looks at the movement of red blood cells. And if we look at, again, the different task force and consensus, all agree that the most important thing is to improve tissue perfusion, yet pressure measurements are used as surrogates. And of course, there is a very poor relationship between pressure and flow. So if we look at microcirculatory shock, or the inability of systemic variables to influence the microcirculation, you can see here that over wide ranges of cardiac output, there is very little effect on tissue perfusion. So one needs to look at tissue perfusion directly. And when does so, one must also be aware of what the two important determinants of tissue perfusion are. They are, on the one side, convection, which is the number of red blood cells which enters a field of view. All of resuscitation medicine is based on the idea of promoting that by chasing cardiac output or manipulating blood pressure. But equally important is the diffusion distance in the field of view. So that's the distance from the red blood cell to the tissues. The larger the distance, the poorer the oxygen extraction. So in heart failure, you have a normal diffusion but a low convection, and hemodilution, you have a large distance and normal convection. So it's very important to combine these two components when looking at tissue oxygenation and tissue perfusion. And here we see what happens during cardiac surgery. On one and the same spot, we see before and during surgery. And if you look carefully, you will see that before surgery, these vessels here are well perfused. Everything that's dark is red blood cells, the hemoglobin in the red blood cells. Once hemodilution sets in, you see that here in the large vessels, there is still flow, but you see large empty areas in between, showing the problem that the body has in extracting oxygen because the diffusion distances are large. And of course, this happens directly as a result of the hemodilution. And here we see, using spectrophotometry, the enormous dip in tissue red blood cell availability during cardiac surgery and how this is corrected by a blood transfusion. And in fact, blood transfusion is the only real therapy that is present, which allows the red blood cells to enter unperfused areas. As we can see here, before and after blood transfusion, we see the density of the perfused vessels increase with no effect on the flow. So blood transfusion affects diffusion distances, but not convection. And of course, as we had done this in this early study, looking at MEAC, this is exactly what MEAC is so excellent in performing. It has a higher hematocrit than normal CPB, and as a result of less dilution of the blood and the poor oxygen transport in diluted blood, it results in less kidney injury, as shown by Engel, with a higher hematocrit and a higher microvascular density. So this is the key mechanism, I think, from a hemodynamic point of view, which MEAC approaches. So let us look at really what's going on during cardiac surgery patients. So this is a study that we did in which we looked at and asked the question is, where is all of this fluid going? Liters and liters of the stuff is given. Water with salt in it, with zero oxygen carrying capacity. So we looked at the cardiac output, we looked at the microcirculation and the bioimpedance in post-cardiac surgery patients with fluid overload. So what you see here up on the left is indeed what happens when you give fluids is exactly what you hope, an increase in cardiac index. But just because you've increased the cardiac index has a disastrous effect on everything downstream. Because as you can see here, you get a lot more, a lot less red blood cells in the tissues, dilution. But the most interesting is, where does that fluid go? So since we've not allowed to use starches anymore and we've got crystalloids, the crystalloids don't remain in the vessels. They pour out into the tissues and increases extracellular water, as you can see here very nicely. But what also happens is a decrease in intracellular water due to the osmotic pressure. So crystalloid resuscitation causes intracellular dehydration, and that is associated with protein degradation. It's a whole other story, but giving fluids does not correct, at least for crystalloids, does not correct hypovolemia, as you can see here. So what about the other, the deresuscitation? So there are various ways of deresuscitation, as you all know. One is to give Lasix. And here you can see very nice in day 1 and day 3 that in Lasix therapy, in one and the same place, you can see how you can recruit the vessels again, getting rid of all of this unwanted fluid, and you can increase the diffusive capacity of the microcirculation, and therefore also increase the oxygen extraction availability of the tissues in the organs. So we combine the resuscitation parameter, we combine the diffusion and the convection components into one parameter as a new resuscitation target. We call this tissue red blood cell perfusion. And as you can see here in this animal experiment, if you continue to do extreme hemodilution, what happens, of course, when you do that is the viscosity of the blood gets lower and lower, and the velocity starts to increase. So if your perception of tissue perfusion is velocity, the velocity, as you can see up here, increases with excessive hemodilution. The tissue red blood cell perfusion, however, which is the perfusion of red blood cells, which is the oxygen carrying capacity of the blood, decreases. This very nicely shows that this tissue red blood cell perfusion is an interesting parameter. So we use these concepts recently to show what happens in COVID. And there you can see some very interesting hemodynamic effects, that you've got the body, it has got to have tissue, it's got to have oxygen extraction capacity. And what it does, as you can see here, is you see a decrease in the systemic hematocrit, and the hematocrit moves to the tissues, and you see that in the tissue, the systemic hematocrit goes up, and in the the microcirculation hematocrit goes up, whereas in the systemic, it goes down. So you see this adaptive mechanism, which can only be seen if you look at the tissues. Simultaneously, we see an enormous increase in the amount of leukocytes in these COVID patients. So does things like that happen in cardiac surgery? Well, yes, they do. Here we see the tissue red blood cell perfusion, which goes down during surgery. This is a study done by Emmanuel Favaron and Wim Jan Bove, who you all know very well. And you see at the same time an increase in inflammation. So the two aspects which we think are deleterious occurring during a cardiac surgery, which is a hemodilution resulting in less oxygen extraction capacity, plus an inflammatory hit by leukocytes, are happening together. And our expectation is that MEAC can address both of these issues. So recently, in the last year, we have now introduced a new device, which we call the OxyCam. It has got different light sources, which gives us better optical images. We can then superimpose the two images on each other and get maps of oxygen. We have embedded artificial intelligence into the device to be able to analyze the different effects. And here we have already proved that with AI, we can identify COVID. And we have got an international base in the cloud of now more than 1,000 patients, all measuring microcirculation, which allows machine tool learning and AI applications for a large variety of patients, including cardiac surgery patients. So here you just see one example of what it looks like, a map showing the different oxygen carrying capacity in the venules, which is blue, less oxygen, and in the capillaries, more oxygen. And Dr. Merkin, you will know that Chris Ellis has done similar things like that in animal experimentation. So it's all about the microcirculation. In the second part, I just want to focus on the cytokine load that we get during surgery. And one of the ideas, at least in the sepsis world, is to decrease the storm of cytokines occurring by having a cytokine hemoabsorber in the extracorporeal circulate. This particular one that we have worked with quite a bit is called the cytosorb. And here you can see all the different cytokines which are absorbed by this technology. So if we look now at sepsis, here seen in the health, and here you can see sepsis, you can see with all of these plugged vessels, again, why the tissue oxygen extraction is down in sepsis, and that this is one of the main causes of organ failure in septic patients in the ICU. And vasoplegia following cardiac surgery looks very much the same. And conceptually, the two are very, very similar, also caused by the enhanced levels of cytokines being produced by the ischemia reperfusion and the plastic pipings in the extracorporeal circuit. So we did a study on a retrospective study using a new propensity scored weighted study in which we used the inverse probability of treatment weights to actually demonstrate a 20% survival improvement on much higher SOFA scores patient than ones without the cytosorb in these sick patients. And what was impressive about this is that the very, very high SOFA scores that these patients have, I mean, these are 75% of these patients usually die. So in the case study now, we looked at what that is, how does that translate to the microcirculation in this case study. And here you see the microcirculation of a septic patient, and you can see here plugged vessels, and you see that after 24 hours, you still see that these plugged vessels are not resolved after without any cytosorb. And here we can see very nicely that all the vessels are now being perfused, vasopressor scores go down, lactates go down after making sure that these cytokines are taken out of the circulation. And currently with Dr. Palman in Leiden, we are involved in a microcirculation aspect of using this in heart failure patients undergoing cardiac surgery, and hopefully when we include more patients to this, we will see what the effects are of putting a cytokine hemoabsorber into the circuit during cardiac surgery. Thank you very much for your attention.
Thank you, sir, for this impressive and scientific presentation. And unfortunately, we only have 10 minutes to go off the programs, and we have another session. So we need to close this session and just need to get to start to the other session. We only have 10 minutes left. So thank you very much for this impressive.
No questions? I would prefer to have some questions. I've been waiting for 2.5 hours now for this session. So no, that's not a good idea. I would like to entertain some questions. I'm sorry, Dr. Gunaydin, but
so
we can't
Prakash,
rush this off.
You ask your question.
Thank you. Thank you, Sardar. Thank you, Ken. I'm sure you're well aware of Ken Taylor's work where he did intramitral microscopy and tried to look at the flow of lymphocytes and during the cardiopulmonary bypass and demonstrated it very well. I was a research fellow at that time and did a lot of work on that as well. And we defined the SIRS and we used various techniques, and those were the days of aproteinin. But what is interesting now is really we did not have we used to exteriorize the gut in animal experiments, and then in patients we used to my personal project was looking at the corneal circulation to try and look at the microvascular. But this device that you have that you're using for the sublingual, that seems to be a remarkable progress and achievement. And I think what I was trying to see, one of the things which we wanted to do, which we couldn't get to do and see how we could ameliorate, was the effect on deep hypothermic circulatory arrest, patients undergoing that, and recovery from that, and the amelioration of the inflammatory response. And we looked at all the various parameters, like you said, cytokine release, and we went through the whole pathway and looked at every single component. But it's just interesting to hear this and all those thoughts of my research days coming back. But what would you say would be the advantage? You've come a really long way in having that. Thank you. Wonderful presentation.
Thank you for your comments. There are just two brief results on that. First of all, we can look sublingually, which we've done a lot on cardiac surgery, but you can also look at it in the surgical arena. So we've looked at liver during liver resections. We've looked at tumors. We've looked at practically every, including the brain, directly on the brain during neurosurgery, etc., and also to the eye. So there's a lot of different, and each of those organs has got its own specific story when we're talking about pathophysiology. I think that's the most important thing. But from a cardiosurgical point of view, really the largest impact, negative impact on outcome is fluids.
Yeah.
And I really do think that that is why I'm interested in MEAC, because it's the only, so don't give fluids, just find a way of avoiding fluids, because fluids are dangerous drugs. That's just as a physiologist. Thank you for your comments.
Thank you. Well said. Thank you very much.
Thank you. And Ignacio, you were asking.
Yes, this is a really interesting presentation. Thank you so much, Professor, for your sharing. I believe that it is really important to assess the microcirculation aspect today in the context of macrocirculatory management. Today, in our clinical practice, we use a macrocirculatory aspect, not have a benchmark for microcirculatory individuation and benefits. We use the extraction oxygen ratio, we use the mean arterial pressure, we use the VCO2. We don't have a benchmark. Thank you so much for your sharing and for this beautiful perspective in our MEAC procedure. Thank you.
Thank you very much for your kind words.
Thank you. And I also want to ask one question. So vasoplegia is something that impossible to have a diagnosis during surgery. So sometimes we do many things and we cannot solve the problem, and we say it should be vasoplegia. So is there any way by your devices to say that this status is vasoplegia during surgery, for example?
Well, thank you very much, Serdar, for this question, and also for the opportunity of allowing me to respond to some of the questions. So I really appreciate that very much. I have been really interested in vasoplegia. You know, it was something that completely, we've done so many years in cardiac surgery, and all of a sudden, you know, I'm hearing more and more about vasoplegia. It seems to be very specifically associated, but you know this better than I do, of patients who had previous heart failure and are coming to surgery, and they seem to have a much higher prevalence of vasoplegia. There is really a very clear image that you get in vasoplegia, which is very different than anything else. So under normal cardiac surgery, it's dilution, which you see, and basically you see all the vessels that have got red blood cells you see are patent. But in vasoplegia, you see plugged vessels, basically. It can be quantified, it's very clearly available, and it's got a very bad prognosis. So that's why we hope that with this CytoSorb trial that we're doing, which we can directly image the microcirculation, we might be able to improve the outcome, because once they get to the ICU, as you know better than I do, these patients have a very poor prognosis.
Thank you very much.
Just lastly, thank you very much again. A very stimulating presentation, and I particularly look forward to this new dual wavelength technique where you'll be able to look at actual potentially oxygen extraction in those tissues. I think that's going to be really a fascinating amount of work. So we look forward to further updates on that. Thanks very much.
And please give my my regards to Ellis, to Dr.
Absolutely,
Ellis.
yes, I'll let him know.
Thank you very much. So, seeing no other questions, we close this session. Thank you very much, Professor Inge.
Thank you.
And now
Okay.
the next session. So, Professor Elstesiadis.
Yes. Well, thank you everyone for participating to this very interesting session, which actually incorporates all the clinical practices regarding this technology. I think it was quite provocative and also very interactive to what has been discussed, to all the topics. And now, before closing, we have an update in the new study that succeeded the COMICS trial. As you have heard yesterday, we're about to publish the results of the study that has been discontinued due to the COVID situation, and now we have a more pragmatic study that has been already launched by MiECT. It's MEAC study, And we have with us Polychronis Andonitsis, who is coordinating the study, and he will present the update on MEACs.
Okay, thank you very much. I'm Polychronis Antonitsis, and also it's Kaylee Dombri. She's the research associate from Aristotle University of Thessaloniki, and we are responsible for coordinating the study from the administrative part. So, in very, very few words, a minimally invasive extracorporeal circulation study versus conventional CPB in patients undergoing cardiac surgery. This is MEAC. It's a randomized control trial that is actually designed for the real world. The real world is that conventional cardiopulmonary bypass is absolutely safe and effective in performing cardiac surgery, but it still needs to preserve physiology more. So what we actually know up to date is that we have evidence-based guidelines that MEAC should be considered as a standard over standard CPB systems that offers increased biocompatibility, reduces the need for transfusion. It has been incorporated into the recent guidelines, but we still need high volumes randomized control trials in order to answer the question whether MEAC in the real world is a better perfusion technique compared to conventional CPB in terms of reducing serious perfusion-related clinical complications. And I say perfusion-related because we need to focus on these complications mainly. So the hypothesis of the study is simple: is MEAC more effective compared to conventional cardiopulmonary bypass in most cardiac surgery operations using extracorporeal circulation? And we will calculate the difference in the percentage of patients having a primary composite outcomes during the first 30 days after surgery, because this is the time frame that the effect of carbonyl of the CPB is more evident. And also we have secondary outcomes that are quite important. The composite primary outcome consists of death, type 5 MI, that is the postoperative MI, stroke, acute kidney injury, all phases of acute kidney injury postoperatively, need for prolonged mechanical ventilation, reintubation, reoperation, and septicemia confirmed by microbiology. So this is the primary outcome, and secondary outcome, it's blood products transfused, postoperative atrial fibrillation, ICU and hospital stay, other serious adverse events, and health-related quality of life as evaluated with EQ-5D. We know from the Titer 2 trial that in series including less than 50% of coronary artery bypass grafting, we should anticipate for a complications ratio of the primary outcome almost at the level of 20%. And actually, acute kidney injury represents one of the most common outcomes, postoperative outcomes in cardiac surgery. And I would like to stress this, by using optimized extracorporeal circulation circuits together with goal-directed perfusion, we anticipate that we really reduce the incidence of acute kidney injury. So actually, Marco Ranucci, in his gifted trial, actually predicts that acute kidney injury of any kind is almost 25% in the control arm versus 15% in the arm operated with following goal-directed perfusion. The procedures, it's different from COMICS trial. We anticipated to recruit 50% coronary cases and 50% valve cases and valve plus coronary cases. So 50% coronary cases, 50% cases including a valve. And according to the power analysis, we have calculated that for a power of 80% and considering that the primary outcome is at the level of 20%, we need about 1,200 patients in order to have sufficient power. So we designed the study, and these are the study arms. We have designed the study according to these figures. The eligibility criteria are the same with COMICS trial. For all those who participate in the COMICS trial, there are very, very few eligibility criteria. Literally everyone is eligible to be recruited into the study unless he's having an emergency of salvage procedure, requirement for major aortic surgery, and contraindication to transfusion or an acquired blood disease. Mainly, we have to recruit 1,300 patients, anticipating also the attrition rate in order to detect a difference in about 30%. So the outcome in a conventional will be 20% the primary outcome, and we need to find a risk difference approaching 6%. And regarding the study center, Thessaloniki, Bari, and Ulm in green are recruiting. Ulm has temporarily stopped, but I think he will come back. And we have connection with the UK centers, Hammersmith, Papworth, and Hull, and we're about to sign the site agreement. Ankara in Turkey, and Izmir, Toronto in Canada, Göttingen, Braunschweig, and Regensburg in Germany, and Coswig, Switzerland, Bern, Ancona in Italy, and we have discussed with the center in Kuwait, who also wants to enter the study. So, is the study feasible? We need to recruit 1,300 patients, and considering that we recruit 30 patients per month, I will say, for all these centers, this will take approximately 3 years and 4 months, and this is feasible. This is a real-world study with optimized extracorporeal circulation circuits. And this study is actually led by the clinical research unit of the Special Unit for Medical Research and Education in Aristotle University of Thessaloniki. Chief investigator is Professor Kyriakos Anastasiadis, and I will serve as the study coordinator. The Special Unit for Medical Research and Education in Aristotle University of Thessaloniki is a newly developed unit that has the experience and the means of conducting the study. Principal investigators are Andreas Liebold, Serdar Gunayuddin, Prakash Punjabi, Ashraf El-Ezawi, and Cyril Serik, up to date. And also, it's very, very important that the database is totally objective. It's the Dendrite Clinical Systems, a leader in clinical databases, the one who hosts the National Registry of the UK, and actually Dendrite collaborated with MiECT in having a database that will be very, very easy to access and very, very easy to use. The Trial Steering Committee and Data Monitoring and Safety Committee, the chair of the Trial Steering Committee is John Merkin, but he's the former president of MiECT and an eminent investigator. And also the Data Monitoring Committee, the president is the professor of medical physics and informatics of Aristotle University of Thessaloniki, Panagiotis Bamidis. This scientist actually will help us in having good data. What's the progress so far? The study protocol is ready. We have IRB approval from our university. The database is ready and it works. The center approval has already started and it works every day. And the recruitment rate so far is low. It's 55 out of 100 and 1,300 patients. Mainly, Aristotle University contributed with 19 patients, Ulm with 31 patients, and Antea Hospital in Bari with 5 patients. And about the procedures, as expected, coronary cases consist the vast majority, but we need to increase the recruitment of aortic valve cases and mixed combined coronary and graft cases. So that's why I would like to personally address the participants online and live. Bernhard Frelchinger from Regensburg, Ashraf El-Ezawi in Göttingen, Cyril Serik in Toronto, Serdar in Ankara, and potentially Marwa in France and Vadim Popov in Moscow, Naren Murjani from Cambridge to actively join the study. Please join also Prakash Punjabi from Hammersmith. Prakash Punjabi is the lead center for non-EU countries. Please join the study. You will tell that there are a few obstacles that are minimal, are bureaucratic, are technical. Join the study. The database is ready. The patients are there. And we opt for, it will provide results that will improve, that will increase the impact of MEAC in everyday clinical practice. We're almost there. We're almost, as Professor Anastasiavi said yesterday, by 2031, we will have a clear view, and we need to be there in 2031 with real results and optimal results. So I actually would like to give my turn to Kelly Dombry, who is a research associate of Aristotle University of Thessaloniki, and she serves as our administrative liaison. Thank you.
Hello, I'm really glad to be here. This is my first meeting to attend. I'm actually a pathology resident and researcher and into clinical trials for several years now. What I'd like to add at this point is that clinical trial design is an important aspect when conducting a clinical trial. So upon that is the first step to achieve reliable results, research results. So here, when we see also previous studies, and from previous studies we can learn, and we can learn how to overcome obstacles, how to overcome mistakes and limitations. So MEAC study is a well-designed clinical trial, and at that point, we have achieved the first step to have a good design, and the second step, of course, is the fulfillization and to fulfill the recruitment target. So we are recruiting, we are enrolling, we have several sites some sites that have been already activated. We are about to activate some more, and we are looking forward to exchange some more emails, and we will continue to do so with all of you doctors and to address any administrative issues. Thank you.
Okay, so thank you both for updating us on this study.
May I have a comment?
Yes, you will all have comments. So what I would say is we will accept questions and comments, just one or two, but try to get them concise, so as we will not have that much of a discussion. And I will circulate first the mic to the online participants, and Professor Pujabi first, of course, because he's leading the UK. Yes.
Thanks. I think Narayan also wants to speak, but I just quickly wanted to...
You will all speak. Don't worry, all of you.
Thank you. Thank you for giving me the first. I'll make it very concise. We are just in the regulatory process. Everything else is moving. It's just the regulatory process is taking time. It's not about not wanting or not wishing or not willing. It's all about going ahead and doing it. And I think I have my research fellow who's liaising very closely to try and progress it very fast. So my apologies for the slowness, but it's all about logistics, not about the key willingness. Thanks.
Okay, thank you for the comments. I thought we have questions as well. But we go on. I know Narain, 25 years.
Nice to see you, Kyriakos, and thank you. First to say congratulations on putting forward this study on the back of comics. I think it's really important, and as Prakash has said, we are very keen to join. The desire is there. There are some bureaucratic issues, but they're not insurmountable, and we will be there with you to support you moving forward. My one question is, listening to the stimulating discussion yesterday about the comics trial, are there opportunities to learn from that? I think as Kelly has alluded to, so there was talk about 36% use the cardiotomy suction. There's the discrepancy about autologous priming, whether that should be allowed in the conventional arm. So my question is there something we should learn from the comics trial about so that we can ensure that we can demonstrate the differences? I think listening to some of the presentations yesterday, we hear a lot of the changes in the technology, and those changes in technology are being applied to the conventional arm. And it may eventually, I think it was alluded to, that may take away the major differences. So is there something we could learn in this trial? I appreciate it's been set up and has started already, but it's just something, a comment to think about.
Well, if I can have the first answer, a lot have been learned from that study. That's why I said this is succeeding, but it's a different study. It's a more real world. The first is the case mix. As you have seen, the comics had 85% cabbage cases. This is 50%. And from all the cases, none of the centers can do more than 50%. So it will be a real world study. From the other 50%, 2/3 will be AVRs and the other third would be combined cabbage plus AVR. So we're trying to have the real world case mix that will make a difference. The second is, as Polychronis pointed out, we have more realistic outcomes, like the acute kidney injury, as you have seen, which is a major issue. And instead of having some very, very rare outcomes as we had, like gut infarction or something very extreme in the comics, we have now very, let's say, real world outcomes. The other one is the blood. It hasn't been calculated well in the previous study in the comics. We don't even have the volume of the blood use, and unfortunately, there was a liberal use postoperatively that diluted a lot what has been the outcome intraoperatively, because intraoperatively is very statistical significant what has been done, and postoperatively this liberal use diluted a lot the results. So a lot of other parameters, as you pointed out, we're trying to do a real world study, and that's why we actually now trying to compare MEAC with OPEC. Whatever people think is optimized circuit, moving from conventional, which with the efforts of this society, it's abandoned, and now conventional is actually optimized with any custom made, but it's not what we used to have when we were training couple of decades, 3-4 decades ago. So for me, this trial, even though it has 1,300 target of patients, it will reveal definitely if there is a significant result or not. So that's my answer. I don't know if Polychronis wants to add anything.
No, these are the main issues. Whatever Gianni said, we have a reduced rate of primary outcome, so we increased the rate of primary outcome by including acute kidney injury in all phases. We had more simple cases. We have increased the complexity of cases. And also we had a liberal transfusion protocol that actually obscured the effect of reduced hemodilution during MEAC. We will apply a more strict transfusion protocol perioperatively so that we'll have more solid results. And regarding the technique, we will try to avoid to have a more correct MEAC strategy applied. Ashraf?
Yeah, actually, from my point of view, there are two aspects to consider in your question. The first was the study, the design, which has, both Kyriakos and Polychronis have elaborated on. But the other issue is we actually, of course, the first step in such a big multi-center study is analyzing your data and getting those published so that everybody is satisfied we did the hard work and in design and in conducting the study. But the second part is going into details of your analysis. And I think this is an issue that we have to address. We have to have a look at these results. We have to unmask the centers. We have to have someone who is really an expert in MEAC going into these MEAC cases and analyzing why did we have such a high rate of cardiotomy suction in MEAC cases. This was from all the results that I've seen, and I've seen, we had the results presented almost 6-8 months ago in a meeting in London. This was the most shocking result for me, and I'd really like to go into details analysis, why, where, and when. Obviously, all of our centers, even the most experienced ones, do have minute differences in how they're handling things. And as we allowed a lot of centers to take part, we should go into detail and look what are we doing differently and where is the best impact. perfectly acknowledge that Thessaloniki is highly experienced. I think that Braunschweig is highly experienced. I think that Bern is highly experienced, but obviously we're all doing something different. And I have no problem at all in, when the facts speak for anything that I'm doing not perfect, to learn from Thessaloniki, to learn from Bern. But the only way of learning is looking at their results and comparing them to mine and seeing what they're doing differently and what I can improve, or maybe what I can transport elsewhere.
Okay, let's go on. Philip de Sommer is the president of EBCP. Comment for the trial, the new trial, Philip.
No, not really. I'm very pleased to see now that it will be compared against, let's say, the optimized conventional ECC. And I think that's important because that was a lot of criticism, I think, in general, on many of the previous studies, that they were not always reflecting contemporary perfusion skills. So I think that's a great step ahead. And I'm really looking forward to see these results, because they will be, in my opinion, very interesting, especially the fact that you also now incorporate acute kidney injury, which I believe it's a major morbidity, which is still underestimated.
Okay, thank you. So Adrian, your side?
Yeah, thank you for going forward and still doing studies on that important issue. And I also agree in what I hear in this morning. We need that modular setup, even for new conductors, for new centers coming to MEAC, but also for the complicated cases. And that would be, in my eyes, the way, and hopefully also the game changer, that more colleagues are using optimized, minimized, better perfusion systems. It's a good way. Thank you.
Don't forget that we are waiting Kosvik to come on board, Adrian.
I try my best not to disappoint you again.
Thank you. All right, so let's see if from the on-site panel are comments. I think President, Mr. Serik.
Just a comment that Rob Baker has made on in the chat is very important, that the conventional arm represent current and contemporary practice, which still uses techniques such as RAP routinely. A pragmatic trial is, as presented today, is great. So yes, I think we're answering that with using optimized extracorporeal circulation as opposed to just conventional. We also have just one comment or question from online from Amit Daylan from Turkey, and he just thanks to all participants for presentations. Do you offer retrograde and antegrade priming if you have a cell saver? Are these priming methods still necessary if you have a cell saver? And I think to Can's presentation, yes, I think it's imperative that we do antegrade and retrograde priming for all MEAC cases. You can always give that volume back if you need it. A cell, we know the deleterious effects of deleterious effects of hemodilution and what that causes. So yes, I think RAP is very important. Cell saver, the cell saver is not really the answer. I think most cases you should only be seeing about maybe 200-300 mils of blood loss during a case. Like, you shouldn't be seeing liters of blood. So a cell saver is not really going to help you with hemodilution. And if you do see a large volume going off in the cell saver, you might want to stop everything and take care of the reason why you're actually bleeding. I don't know if anybody else wants to comment on that particular issue.
Okay, so let's go on. I think Bernhard Flechinger, any comment?
Yes, to this trial. I'm not sure about the design because we want to recruit more patients to do MEACT. And somebody said yesterday 20% of all centers do MEACT. And yesterday we saw the comic results, and at least my impression was the three guys on the screen were kind of disappointed about the results. And I'm not sure about the design of the next study coming up to include 3 different procedures, CABG, valve plus CABG, and to expect, okay, they're getting up some other results. This last study was finished because you couldn't achieve enough patients. Will you expect to achieve your patient numbers you want to have with 3 procedures combined? I'm not sure about. Or would it be better to go just for CABG in class 2? Because I think that's a simple procedure, and if you want to convince other centers to do MEACT, then you should convince them for a simple procedure at first, and that's the CABG with class 2 system. That's at least my point of view.
Yeah, I understand your point. The problem is that there are many studies with CABG cases, and also even if you do it in CABG cases, you have the results, as we said yesterday, in higher risk populations, you have a higher expectation of a primary incidence, of a primary outcome. So the percentage of complications increase, and there you can find more significant differences. So designing another study with just coronary artery bypass grafting will not add anything new to the current knowledge. But we need a real-world study that will include literally most of the types of cardiac surgery to show that MEAC is more effective than conventional cardiopulmonary bypass. If we restrict it to one type of procedure, then we will always have the drawback that this refers to only one cardiac procedure. That's the whole point. And if you think that we have achieved more than 1,000 patients, this is the target group of the studies, 1,300 patients. So we have actually adapted the design of the study to the results of the COMICS trial. And I believe that we can have this number of patients.
Okay, so I think we can go on for a long time about this, but I will leave it for maybe another online meeting dedicated to the MEAC study. Whoever wants to participate or need any kind of advice or coordination regarding this, you know now the team, you know the email of the contact of MEACTIS, and you know us, so we are here to help or maybe welcome you on board if there is input. So I will give the mic to my co-moderator, Professor Merkin, to close the update on MEACT study.
Yes, well, firstly, I'd like to once again thank everyone that has participated both in the presentations as well as in the discussion. And we know that there's also going to be a significant online audience for this event. And I think once again, this has really been a wonderful opportunity to have a multidisciplinary discussion about these aspects of heart surgery and how best to optimize our patient outcomes. And I believe that this particular society is an excellent vehicle to do that because it is multidisciplinary. And while all of us talk about teamwork, I think the participation in events like these, where we do get a wide range of perspectives on how to address these types of issues is very important. So once again, I'd like to thank everyone who's participated. And as I say, we look forward both to the publication of the COMICS trial, which I do believe will still be a landmark paper, as well as the ongoing progress of the current mix follow-up study. So thank you very much.
Well, thank you, John, and thank you all for taking part in this meeting. We need to close it. what I would say is we had striking discussions regarding current status and perspective on MEAC. We also had a huge input from the industry, and I really thank all these people that are with us the last 10 years. You have heard that COMICS trial results have been submitted to the journals, and we are waiting very soon to have the outcome of our submission. Today's discussions on MEAC in clinical practice actually was the core of this meeting, and I hope everyone really liked all the input from all over the world, from key opinion leaders regarding what we have emphasized on MEAC. And of course, last but not least, the good thing is that the society is active with this study, and I hope we will have soon results. So with this, I want to acknowledge Inventix and Live Media with Stathis, who is actually doing all the PCO work behind this to give us a good results on the publicity. And I would say that so far we had yesterday about 300 live viewers, and today is literally double. We have about more than 14,000 views in our site. That is something not just for us, but for the industry as well, how much interest we can attract with this symposia and meetings that we are having annually. This is the acknowledgement for our university and School of Medicine that is supporting, as you have seen, even for everyone's input. And let's see how it was these 2 days, as we normally do, how we spent this weekend in Thessaloniki. Okay, so with these pictures, what I would say is yesterday we have decided that the 10th year's anniversary event would be hosted in Athens next year. So I will celebrate this 10 years following the event, the successful event that we had in Athens 2016. So after 10 years of establishment, I hope you will all join us in Athens to give the update of what we are doing and how we're visioning the patient advancement care. So don't forget to register to MEACT through the website that you can see here, because it's complimentary. And with this, I will pass on to the president of the society to close this meeting. So, Cyril.
Thank you very much, Kyriakis. I think we've had a very successful meeting here the last day, I guess, half day yesterday, half day today. We've had a number of participants online, media and live media. We've also had CTS.net, where this meeting was available through CTS.net and YouTube channel. One thing I remember when as I was in line waiting to get on the plane, and you see those billboards that they have with all the advertisements and everything. And one thing that struck me is I read, "Is family where you're from or where you're going?" And I reflected on that and said, "Wow, family is, I'm certainly leaving some family behind to come to this meeting, but I'm also going to meet a lot of my MEAC's family." So, we are a very coherent and great group of people here. And, to reiterate what John has said, this is a multidisciplinary society team. This is truly the only multidisciplinary society that exists. We have cardiac surgery, anesthesia, and perfusion. We've had 2 presidents have been cardiac surgeons. 1 president has been an anesthesiologist, and myself being the first perfusionist president. So, we are a true team, and this is, I'm very happy to be able to say this is a true family. We come here, we gather here to talk. We're passionate about MEACT and MEACT. But I think the real reason why we come here is for the people that are out watching online and participating online. We want to disseminate what we know and what we believe is the future of cardiac surgery. And the only real reason why we're here is for you guys out there. So I think one of the big things is if you're thinking about starting a MEAC program, if you need help continuing with your MEAC program, please feel free to reach out to us. We're all here. This is what we do. This is what we're about. So please feel free to reach out to us, and we'll help in any and every way that we can. So with that, I want to thank everybody for participating and close this session. So thank you very much.